Thank you, Jeremy. Welcome et bonjour à tous. Sur une excellente journée comme aujourd'hui, nous comprenons pourquoi la plupart des médaillés olympiques viennent au Québec, viennent du Québec. I'm going to ask my panel to join us here, and I'm just going to say a few comments, and then I'm going to get the panel underway momentarily, if I may. Pourquoi sommes-nous ici aujourd'hui? Nous sommes ici aujourd'hui parce qu'un certain nombre des organisations nationales représentées ici, y compris le Conseil de santé du Canada, l'Institut canadien d'information de la santé et la Fondation canadienne pour l'amélioration des services de la santé, ont clairement montré que bien que notre système de soins de santé produit les résultats raisonnables mais excellents en sorte de certains domaines, mais pris ensemble, ils ne sont pas grands par rapport à nos homologues internationaux. En bref, nous pouvons et nous devons faire mieux. La meilleure façon pour nous de faire mieux, c'est d'améliorer 3 aspects de soins de la santé, le triple aim, amélioration de l'expérience des patients des soins, y compris la qualité et la satisfaction, améliorer la santé de la population et la réduction de croissance des coûts des services de santé. We believe there are a few pathways to achieving these 3 objectives. They all lead to one common pathway, which is leadership. Leadership matters, and several kinds of leadership are required to achieve these objectives. First of all, and probably under-recognized, clinical leadership. Clinical leadership by nurses, physicians, professionals in the systems who understand best systems of disease management and the microsystems that are required to assemble, instrument, and manage in order to better control and manage complex chronic disease that is characteristic of our aging population. Policy leadership. Policy leadership by politicians, but also by senior officials who play important roles in making determinations about the organization and financing of our delivery system. Executive administrative leadership, chief executives, senior executives within the delivery system who are working very hard to deliver better services in their own organization, but also are required often to step up and engage in policy leadership and policy activism in order to get right decisions made as we move forward. Patient leadership, and we have good leadership here from the patient community in Canada today. And finally, leadership without position. There are plenty of actors in our delivery system who do not occupy positions or posts of authority: journalists, policy researchers, health services researchers, patient advocates who have voices to be brought to the table. And there is no single formulary for how this all gets done. In a very fundamental way, leadership is about 3 important things. It's about managing people, it's about having a good strategy, and it's about execution. And all of those are required to make reforms and to deliver on our 3 big objectives. At the end of the day, what counts is getting results. And today is about how we can help to build capacity within our fragile federation to be able to achieve results in a coordinated way. We'll have an opportunity at the end of the day to kind of try to do a stock taking together about what we need to get there. What are some of the capacity building mechanisms that we need? How do we do this in the challenging federation we have? We have interesting federal, provincial, territorial dynamics at play. We have the exceptionalism of the province we're living in here in Quebec. We have to be able to build capacity nationally and regionally to make this happen. So, we have a few programs across the country. We need to ramp this capacity up pretty dramatically. So let's move quickly to our panel. We have 3 excellent thought leaders to begin. I'm going to introduce first John Abbott, and all of our panelists have their bios laid out in elegant detail, but In short, John has played a long career of senior roles in health policy as the Deputy Minister in Newfoundland, and most recently as finishing a very successful run as the CEO of the Health Council of Canada. So John, I'm going to ask you and each of the panelists to try to stick to about 7 minutes. There's a clock running here, and I'll try to keep us on time. So the floor is yours. Please welcome John.
Well, I'll be happy to know when I return to St. John's that I can put on my resume thought leader. There are lots of thoughts going around, but leadership on thought and development and ownership is equally challenged, I think, at times. And in Newfoundland, we are coming through a very interesting political period. We are now on our third premier in just a couple of years. And like healthcare, the leadership is changing, and the momentum for improving the society is languishing. So thanks very much for the opportunity and to be here today. It's something I've certainly been looking forward to, doing some contemplation on the topic, doing certainly some reading, reviewing actually some of our own reports in areas that at the Health Council that we've been focused on. And so if we think of the health accords of 2003 and 2004 as a watershed moment in the evolution of Canada's healthcare system, what would you think would be one of the factors that allowed those accords to, in fact, be put in place? And at the same time, we'd ask you to think what has been missing really over the past 10 years, or at least as the decade unfolded, when we talk about the evolution of Canada's healthcare system. And I would say it's leadership. We've certainly had the resources and continue to have the resources dedicated to our healthcare system. We've certainly had, through the Accords and elsewhere, a lot of policy and program direction. We have a sense, generally, I think, where we want to go. And we've certainly had the capacity to make the change. And certainly the people in this room and the organizations that we represent, I think, can speak to that. And I think we've all been engaged. And I think there's also a high degree of consensus of any of the conferences, any of the conversations I've had with the politicians, with the senior bureaucracy, with health administrators, clinical leadership. After a few minutes, it becomes very apparent that I think that we all are striving for and towards the same goals. So at the Health Council of Canada, we've sort of, how do you assess this issue, and how do you move forward? So we looked over the past 10 years. We've developed a report. We think we've done it in a systematic way. We've looked at the literature. We've looked at the empirical evidence where it is there. We tried to look at what's happening international to really tell us what is possible. And when we compare ourselves to other leading countries when it comes to healthcare, obviously we find that there's a lot wanting in our results. Not so much in our system, but certainly in the results that we have achieved, or more importantly, have failed to achieve. And I guess our conclusion, no surprise to I think many of you here and people outside this room, is that we are performing at levels well below what we want, and more importantly, we're not meeting our expectations and those of the population. And we've looked at factors of spending and outcomes and health status, and over we rate below our peers. And more interesting, I think, is when you look across the country, where we see such wide variation. So not only are we below what, as a country, what might be some norm, within Canada, we are at the provincial level well below those, even the Canadian norm, relative to what is happening internationally. And that should be a concern for all of us. So how do you try to bring all these pieces of information together and perspectives? And I think that's where the triple aim framework certainly enters the picture. When we were developing a report on better health, better care, better value for all, we looked at different frameworks nationally and internationally, and kept coming back to triple aim. And we felt that it had enough rigor to allow us to look at the past, but more importantly, to plot a future of transformation for our system. So what do we need to do? So if you look at triple aim and build a strategy for reform, either at the organizational or system level, at provincial or national levels, once you have whatever framework you want to use, or a variation of it, and in this case, we felt with triple aim, one thing that we felt needed to be added, or at least brought out and put forward in a more meaningful way, was the whole issue of equity. Because the political and social reality in this country, certainly based on my experience, both in Newfoundland and certainly in the work at the Health Council, is that Canadians, no matter where they are, walk of life, whatever income strata, they want to have access to the best quality health care. And on the flip side of that, those that are designing both at the policy and program levels are also working towards developing those programs and policies to in fact, that equity is achieved. And that's no mean feat for a country this size. Now, we know that when you look at that, there's anything but equity in our system. But the political and social value set suggests that that's where we need and should be focused on an ongoing basis. So consequently, we thought we should bring that out. So the question then is, in trying to achieve the goals for our system, who in fact is speaking for that? Where is the leadership? We think we have everyone on side here to move forward. But if you take just this week, the whole issue of mammography screening, where is the leadership on that issue today? We have, yes, it affects women at high risk of cancer, but it affects all women and consequently affects their family. It affects society as a whole. But who's addressing that issue? Do we hear anything from the Federal Minister of Health? Do we hear anything from a provincial minister, the Council Federation, you name it? So where do we go with those kinds of issues? This week we put out a report on screening that speaks to that whole issue of how we move that agenda forward. And the one thing we found there, yet again, was the absence of leadership. Now, I know my time is up, and I just got one quick, I'll just jump ahead here. So, ask yourself, with the knowledge we have, the skills we have, could we not be the best healthcare system in the world? If we had political leaders that cared and led, administrators who cared and led, and clinicians who cared and led. I believe that we agree on one common set of goals or a vision for the Canadian healthcare system. We can readily draft the necessary policies and legislation, one of the key enablers. We can commit to enhancing our capacity to deliver. We are innovative, but need to accelerate the spread and take up of our healthcare innovations. We know how to measure and report, but again, we need to be ready to accept and implement the results. But without the leaders to action these steps, commit to ongoing implementation and follow through, and be prepared for missteps, there is no incentive to lead. There is no incentive for action, or the actions we take are, in fact, as examples show, piecemeal and lack coherence. So, what do we do? So finally, The Health Council would certainly say we need to put leadership, the topic, and focus on leadership at the head of any agenda. And I'm glad the three organizations have really pulled together to do that. So as a Health Council, as we say, that's fading to black, one voice on this topic will be lost. So we need others not only to voice the dearth of leadership in this country, but to commit to strengthening it so that our healthcare system grows stronger and Canadians get the best healthcare and the best healthcare system they deserve. Thank you, Terry.
Thank you. Thank you, John. Thank you, John, for starting us off. We're going to move now to Jean-Louis Denis, who's going to speak in French. So if you want to get your headphones on, that would be a good place to start. And Jean-Louis, many people will know here, internationally recognized talent in health service organization and management. And he's going to talk about plural leadership. So John talked a little bit about administrative policy and clinical leadership. Jean-Louis is going to talk about a very nice piece of work he's done for Academy of Management Journal, talking about what does plural leadership mean in healthcare, and anything else he wants to say. Jean-Louis.
Okay, merci. Oui, OK. Merci pour l'invitation. Je vais prendre peut-être une approche un peu différente et on va essayer de plonger un peu à l'intérieur de cette idée-là de leadership. Qu'est-ce qu'on veut dire par leadership? Et ceux qui étaient au module extra cette semaine vont trouver certaines redondances. Fait que vous pouvez aller prendre un café ou réviser la matière. Mais on va essayer de le faire un peu différemment. Je vais commencer par une image qui est très significative du leadership et qui est très centrée sur les individus. Vous le savez, il y a une tradition quasi narcissique de leadership où l'important, c'est de positionner le leadership comme un trait individuel, quelqu'un qui est capable de se signaler, de se distinguer et finalement qui attire les autres. Il y a une longue tradition de leadership charismatique, de réflexion sur cette question-là. La proposition que je vous fais ce matin est assez simple, c'est que un des grands changements, je crois, qui se passe en santé actuellement, c'est de concevoir le leadership beaucoup plus comme un phénomène collectif que Terry a appelé pluriel. On a appelé ça en anglais plural là, dans un papier. De regarder ça beaucoup plus comme un phénomène collectif et de regarder le leadership du point de vue d'un système, c'est-à-dire qu'est-ce qu'il nous faut comme capacité pour réaliser des améliorations ou des gains de performance. Et là, je vais juste faire une petite référence à un travail qu'on a fait avec Ross Baker, qui est bien connu ici, et j'ai juste mis en couleur trois aspects des 10 pratiques qu'on s'était ou des 10 thèmes qu'on s'était amusé à identifier de systèmes hautement performants de santé. Et il y avait cette idée, de vision et de stratégie tournée autour de la qualité. Un deuxième, l'idée d'un leadership qui traverse le système, et ça, c'est l'image collective et distribuée. Et dans l'introduction que faisait Terry, il y avait du leadership au niveau des politiques, des organisations, de la clinique, je revenais là-dessus. Et beaucoup aussi un leadership qui s'inscrit dans une transformation du professionnalisme, autour du travail d'équipe, autour de la capacité de travailler en complémentarité entre des professions et aussi la capacité qu'ont des leaders cliniques de remonter un peu dans l'exercice du leadership et de s'occuper plus d'enjeux organisationnels ou de système. Et c'est ce que je vais détailler ici par un petit travail qu'on a eu l'occasion de faire à la demande de l'Academy of Management à Annals, qui nous avait demandé une question assez simple. Qu'est-ce qu'on connaît et qu'on connaît pas sur les formes plurielles de leadership? Et on est arrivé un petit peu à une typologie de 4 formes, donc 4 représentations qui pour moi représentent des lignes de force dans la transition vers une conception plus individuelle du leadership à une conception plus collective et qui s'applique, et là je suis totalement biaisé, qui s'applique merveilleusement au monde de la santé, puisque le modèle à l'arrière de cette étude-là, c'est ce qu'on appelait des organisations fondées sur la connaissance, c'est-à-dire des organisations dont la main-d'œuvre, excusez, des organisations, c'est ça qui arrive quand on parle trop dans une semaine, des organisations dont la main-d'œuvre est experte et donc qui ont des capacités de facto distribuées. Fait que si vous tombez endormi dans les 4 prochaines secondes, le premier message, c'est qu'on est dans des organisations où de facto le leadership se doit d'être collectif parce que les expertises, les influences et les sources de légitimité sont distribuées. Le premier cas de figure dans la cellule 1, c'est le cas au fond du travail d'équipe, ce qu'on appelle des team-based organizations. Et ce qui ressort de ces travaux-là, c'est que la performance des équipes, et là vous pouvez dire des équipes de soins, la collaboration interprofessionnelle, dépend beaucoup de la capacité des individus à se partager à différents moments de l'exécution du travail, des rôles de leadership et à le faire de façon collaborative et en complémentarité. D'où l'idée de leadership mutuel. Le deuxième cas de figure qu'on appelle en français pooling leadership, c'est assembler de leadership, c'est de placer, les diapos disparaissent, c'est de placer, ça serait bien qu'ils reviennent les diapos, c'était sympathique, c'est de placer les différentes sources de leadership, à défaut de meilleurs termes, au sommet de l'organisation, dans un mode complémentaire et coopératif, ce qu'on a appelé dans des études empiriques le leadership collectif. Pour exemple, bien assemblé dans une organisation, le leadership clinique et managérial à la tête, entre guillemets, de différents programmes, ou bien au niveau stratégique de l'organisation dans les équipes de direction. J'étais sérieux, hein, ça serait bien que les diapos reviennent, je ne sais pas combien de fois il faut le dire. Merci. Le troisième cas de figure, c'est ce qu'on a appelé spreading leadership, et une des lignes de force à mes yeux, de transition dans les formes de leadership, dans les systèmes de santé, c'est l'exercice du leadership dans des environnements moins structurés, comme les réseaux, où vous avez, par exemple, des médecins dans des cliniques médicales privées, du personnel de santé dans des établissements de soins, des leaders communautaires dans des organisations associatives ou communautaires. Et l'enjeu, c'est de faire fonctionner de façon rotative et complémentaire ces différents leaders-là. Et de plus en plus, lorsqu'on discute d'amélioration des soins et services, entre autres la prise en charge des maladies chroniques, on est dans une conversation qui engage ici ce qu'on appelle le spreading leadership. Et le dernier cas de figure, dans les 20 secondes qui restent, c'est le leadership plus émergent, qui se développe à travers les interactions entre des acteurs qui essaient d'accomplir des tâches concrètes, que ce soit un programme de soins, par exemple. Et ici, on retrouve beaucoup ce qu'on essaie de travailler dans d'autres travaux. Là, j'aurais pu trouver un mot mieux que ça, sur des microsystèmes cliniques et comment des professionnels, lorsqu'on offre un environnement organisationnel structuré en termes d'information, d'incitatifs, de guides de pratique, interagissent entre eux différemment. Et ça représente un terrain fertile pour faire émerger des leaders cliniques qui vont assumer des rôles plus au niveau organisationnel du système. Je suis 32 secondes en retard, donc la conclusion est simple. Le leadership individuel est une belle image qu'on traîne souvent, mais il m'apparaît beaucoup moins adapté en ce moment pour réfléchir aux enjeux actuels et futurs du leadership dans les systèmes et les organisations de santé. Et pour essayer de vous convaincre de ça, j'ai évoqué 4 représentations du leadership collectif. Merci.
Thank you, Jean-Louis, and thanks for keeping the time. Our last speaker is Graham Dixon, who is an emeritus professor from Royal Roads University, who's been working very hard with CHLNet in the last few years, and is going to talk to us a little bit about some research work they've done and what some of the findings have been about leadership issues. So, Graham.
Thank you, Jerry. I think I'll sit if that's okay with everybody. And can't hear me? Okay, that's better. I think I'll sit if that's okay. What I'm going to do, and I see I'm having the similar slide problems that, there we go, it's coming. John made a great case for the importance of leadership for transformation and change in the health system. Jean-Louis made a great case that the kind of leadership we need may be very different than the practical form of leadership we have been relying on in the past. What I want to do is to provide you some information and some data from work that I've been doing over the past 2 or 3 years, partly with Jean-Louis and with many people in this room who I stand on their shoulders, to show what the real challenge of moving to a form of collective leadership presents to all of us and why we must work together to do something to enhance it in this country. My perspectives are drawn from this variety of sources, and I'm not going to talk to them, I'm just going to put them up there. But a number of systematic reviews. I come at this more as a researcher who works with decision makers. I'm not a pure researcher in any way, shape, or form. I tried to build a partnership with decision makers that underpins the knowledge that I'm going to give you. Some of the work comes from what's going on in Australia and the UK. Some of this work comes from a very recently finished CHLNet benchmarking study where we went out and asked decision makers, what do we need to do to raise the quality of leadership in the country, and what data do we have around that? Some is from the FISI project that I've been working on over the last 4 years with Michael Smith and the Canadian Institutes for Health Research. And part of this is John's report, and part of this, of course, all of this flows into the document you all received, which is the Canadian Health Leadership's intention to galvanize effort behind that pan-Canadian approach to developing distributed leadership, shared leadership, collective leadership, plural leadership, whatever you want to call it, to serve the health system. And here's what our research has told us, not about why leadership matters, but why doing something about it matters together. Here's the first statistic that I wanted to share with you. 40% of respondents from ACAHO said that they don't have the leadership necessary to meet the challenges of healthcare in the future. That to me is an amazing statistic. Notice too that the respondents to the CHLNet benchmarking study, and they had a 50% response on a survey, which is huge, of health organizations across the country. 72% of them said they had a skill gap in the domain of leadership. Either a small skill gap, a large skill gap, and in some cases a very large skill gap. This particular quote comes out of the FISI. It essentially says that in this country we're tinkering around the edges of transformation. We play with it, we do incremental change, but none of it lands. There's no large-scale change going on at all. And ultimately, it leads me to make this particular comment that I think pulls together all those sources. That creating large-scale change in this country means that we have to have higher levels of system thinking, strategic thinking, visioning, engagement, skills, and self-leadership capacity amongst all of us together. There's where we have to put our energy to grow our capacity. The second key finding that you'll find in all of that work, I think, is that yes, every single profession is fundamentally important to become part of the team. But a particular profession that needs special energy, special understanding, and special treatment, not special in the sense of better than everybody else, but different, is the physician community. And it was very clear in the FISI study and in many other studies across the globe that physicians have a unique role in the system, and if they aren't engaged as leaders in the system, then we cannot transform it. They will block transformation. So quality physician leadership and a real emphasis on meaningful engagement is fundamentally important. Third finding, we have such churn within our health system, particularly at the senior executive level, that long-term change is incredibly challenging. Politicization contributes to that. By politicization, I mean politics maybe entering into the system in deleterious ways to allowing us to work together to change it. But also, we ourselves have to look inwards and say, do we bring a long-term commitment to a role and a job? And this particular quote from the Fizzy study really hit home for me. Doctors and clinicians are often there for the duration, and they see a revolving door of administrators coming through. And they wonder and they really question what the commitment of those people is to long-term transformation, because large-scale change takes a long time. So we don't get long-term agendas. We don't get alignment throughout the system. We have disconnect actually within organizations. And our Fizzy study shows some of that. Fourth point. John and we talked about collective leadership and shared leadership. One of the things that came out from our studies was that I don't think we understand in some ways the depth of the personal challenge, our own mental models, our own cultures that we bring to the table, how deeply they're challenged by that model of leadership. It really means a collective rethink of our whole idea of leadership, to the depth of our values, our assumptions, and our beliefs. This particular quote came out of the Fizzy study, and it was very important. And we saw it in the Olympics when Denny Morrison gets the silver medal because a player said, "Here, take my spot." That's what we're going to have to do in the health sector if we're going to work together to create the system we want to create. We're going to have to put ourselves in the background and some other people in the foreground. And we're certainly going to have to put patients deeply in the foreground. Just wanted to point out that in the UK, they've now appointed a patient ombudsman whose job it is to contravene the code of silence that exists within the NHS in the leadership cadre. So we need a shared leadership and we need a shared vision for it, and it really is going to challenge our personal notions of autonomy, accountability, and collaboration. And this particular quote, and I'll let you read it, says, "Boy, we're getting tired. Those of us who are out there are trying to do leadership maybe through the heroic model, or we're being worn out. And we need some mechanism to grow our capacity. Otherwise, we're going to go down the drain. As a system, we're going to go down the drain." We also possibly need some standards around leadership that say this is what good leaders do in a collective sense. And we need to work together to create it. Other countries are doing it. And without those standards, from a national perspective, pan-Canadian perspective, it's a bit like being Alice in trying to play croquet in Wonderland. You never know where the goalposts are, where you should be as a leader. We need to create a leadership culture through the mobilization of knowledge. We need to have a national strategy for succession planning and leadership development that is far greater than we currently have. And finally, it is important to have those elements coordinated and the resources from the disparate elements that are going on around the country brought together in a coordinated, organized way. We need to build on each other's strengths in order to do that. And it should link to the reform agenda. That's what we have found in the research. Leadership done in the service of reform, leadership development done in the service of reform, really enhances the growth and development of individuals. The last comment on this is to simply say that we did get a lot of positive responses in a survey that suggests that now is the time for a pan-Canadian leadership development and succession planning strategy. I'm throwing 3 quotes up there that point to that. It's very important that we start emphasizing the positive, that we start working together, and that we work with our clinician colleagues, doctors in particular, to create a coordinated agenda for developing the capacity of leadership in this country that's needed. Thanks, Terry.
Thank you very much. We have a few minutes for interaction. Maybe what I'm going to do is just ask the panel one question to get them primed, and then I'm going to open the floor. We talked at the beginning, I mentioned at the beginning, the distinctions between people management, strategy, and execution. And I would submit, this is a proposition for your reaction, that we actually we know what the strategy is. We've had dozens of reform processes. We have leaders who are capable of engaging people. But we don't have all the technical skills and managerial skills for execution. So actually training and building capacity for people at the frontline level, the clinical level, and the executive level to execute in a different way is part of our challenge. And to say that our politicians are pushing us in different directions might simply be a way of saying that's somebody else's problem. Let the referees tell us what to do. So proposition one, our problem is execution. John, your comment.
I would disagree. I think it is the absence of, a clear, very clear vision that is enunciated and shared and inculcated literally from the premier of the province to the frontline provider. Because right now, it's my experience and what we've seen in our own work, is that there are so many disconnects that we're not quite sure what we're working towards. And at the same time, when you talk to, whether it's ministers of health, any of the clinical leadership, it is, well, we want, the best care we can provide for the best, value, those kinds of things. So, and I think we do have the skills and the people in place to execute, but they're not sure what they're executing on or for whom, and is the plan we're working on today going to be the plan we're going to be working on tomorrow? This speaks to some of Graham's observations through the various studies. So bottom line, I'm back to, let us agree as in any individual system, whether it's in one health authority, one hospital, one clinic, that we know what we're doing, but that it ties back to the ministry, ties back to the political leadership. And if we get that straight, then I think we can move forward very quickly.
Thank you. Graham, I ask you to be brief so we can get to it.
Yeah, I'm going to respond from the inner perspective. I think the challenge isn't necessarily external. I mean, I pointed out a bunch of external challenges, but I think the challenge for many of us is more internal. It's more how we view our own willingness to carry out change, whether we're willing to take on the real challenges of it. And those real challenges are sometimes our different values, different assumptions that we have to play, and actions that we have to take that may, in fact, bring us into conflict with people that we don't really want to go into conflict with. And the ability to push through that conflict for the better good. So I think it's an internal challenge more than an external one.
Jean-Louis?
Oui, on termine un module d'extra sur cette question-là qui est orienté sur l'exécution. Je pense que l'environnement, les politiques, les incitatifs peuvent être facilitants, mais il reste nettement de marge dans les organisations pour aller chercher de l'amélioration. Et la preuve empirique de ça, c'est que dans un même système, un même environnement, la performance va varier entre les organisations de santé, et c'est beaucoup lié à ce qui était mentionné pour moi.
Thank you. Okay, your thoughts. What's the missing ingredient here? We have a clear diagnostic. Where do we need to be putting some of our efforts on leadership? Please, could you just identify yourself too so we can all get to know each other?
And that is all.
Yeah, you have our attention.
Thank you. Well, just after that introduction, my name's Emily Nicholas, and I'm with Patients Canada here. And thank you for your points. And it seems like you're in agreement about the need to move towards a much more collaborative and cooperative type of framework. And I did hear about putting patients sort of centrally or at the fore. But I wondered more specifically your thoughts on how to integrate patients actually into leadership roles and how patients could be partners in leadership.
John?
Well, I guess my sort of
Mike?
Sorry. My response to that is we know today the value of engaging patients. So the question I have in sort of response is, why aren't we doing it automatically, systematically? Why is it still an issue? So anybody here that's in in a health organization that is delivering services to Canadians and are not engaging the patients that they're serving, they're not leading. It's as simple as that.
I'm going to invite a few people here. Kevin, you want to comment on that point about patient involvement? Is patient involvement, patient leadership, engagement key to our reform process?
Hi, thanks, Terry. I'm Kevin Emery with the Royal College of Physicians and Surgeons of Canada. I think patient involvement is critically important. I think it's a challenge for organizations to figure out how to do it in a constructive and sustainable way. It is easier for certain types of organizations and more difficult for others. That's not an excuse, though. I think we need to figure out how to do it, and I think successful organizations are able to do it.
Brian.
Thanks, Terry. Wonderful way to get the conference started on leadership. I'm Brian O'Rourke, President and CEO of CAHSPR, and also co-chair of the Canadian Health Leadership Network. Graham, my comments to you, when I hear you speak, I've heard you speak many times, and we've interacted a lot, and you use the word culture a lot. And I don't think I heard that word here today. And I'm just wondering about the importance of culture to leadership. So many leaders have crashed and burned because they haven't understood the culture of the organization. They've tried to impose a culture into an organization. So no matter how good your leadership skills are, you really have to have a good understanding of culture. And how do you change culture?
With great difficulty, to answer your last question. I was actually having breakfast with Shalom this morning, wherever Shalom Gloverman is, and I was mentioning the NHS patient ombudsman, and of course his response, rightly so, was, yeah, but will they let her do anything? Essentially, will the culture, will the ways of doing business, the way we interact on a daily basis that sits beneath our consciousness and drives our behavior, allow her to be impactful? That's why I was saying it's fundamentally important. The only way you can deal with culture is to surface it. You have to bring it into consciousness. You have to allow people to see it for what it is. If it lies beneath the consciousness and beneath the surface, it impels you rather than you dealing with it. So in an organization, I think you have to have methodologies to surface culture in a way that people at least intellectually can see both the rational and irrational aspects of how they go about their work on a day-to-day basis. And then you can engage them in a conversation about, well, okay, if we deliberately wanted to impact this, how might we go about doing it? But it also means it's an incredibly long and difficult task. More often than not, we approach change from changing the structural perspective and we ignore culture. And that's why many changes don't work.
Careful with that mic.
Yeah.
Yes, Nora Davies from Saskatoon Health Region. I just want to follow up on the question of how do you engage in a meaningful way, patient and families. And in my health region, we now have 180 patient advisors and 15 program-specific patient and family advisory councils. They are changing the culture of our organization, but I'll tell you, it's tough. because the conversations change when the patient and family is in the room, including starting every one of our board meetings with a conversation with the patient or family representative. So I think there are some structural things you can do, but I will tell you that as part of our lean management system, all of our quality improvement initiatives, our 3P events, our rapid process improvement workshops are required to have at least one patient or family member as a full member of the team. And the tension that creates the creativity it generates by looking at things through a different lens is quite astonishing, but it's very tough work.
So leadership in patient engagement, patient involvement in the decision process, the structure and the organization of care. What else?
Okay. Thank you very much. I enjoyed that discussion a lot.
Can you identify yourself?
My name is Deborah Worsfeld. I'm the Director of Leadership Development for Medical Students and Residents at the University of Manitoba. And I wonder if the panel members could discuss the aspect of bringing physicians along on this journey, because if you don't get physicians, you're not going to get it. And how we are going to make that part of our training of physicians.
Oh, that's a toughie. I can start, but I think Jean-Louis probably has much more to say on this. But I would essentially say is that physicians are often trained in a manner that is not receptive to many of the notions of leadership that they might be asked to embrace. And so obviously it has to start right in medical school. There has to be some kind of introduction to the role, them being a leader. And one of the most important points that I'd like to make there is that by virtue of their simple role, they're seen by everybody else as being a leader. What often gets into trouble is they don't know how to behave as a collective leader. And they therefore have to develop those skills. So the more you can develop those skills from the get-go, the better off you are. And the culture of a lot of medical schools mitigates against that. They're very special. They're identified as being very special. And when they come in, they're a unique class amongst themselves. I may be overemphasizing it. But again, it becomes an issue of culture, and it becomes an issue of what can you build into what you're doing in their training that opens it up to the skills of collaborative leadership.
I wonder if I can, I'm going to ask the panelists to give a closing word, but I wonder if I could punt to some of the physicians in the audience. So Barack, we were talking about this morning. Iraq, j'aimerais savoir vos points de vue.
My name is Bruce Baldano. I'm a pediatric intensivist, and I'm a fellow in cohort 10. I don't want to touch the microphone. And I will not. Cohort 10 of the extra fellows. I guess the example you guys had at the beginning, as I started my work as an intensivist, administration was on the other side, parallel. And going through the extra fellowship, learning, better understanding of systems has opened my eyes drastically. So it's education, it's application of whatever you're going to learn into your everyday life. It's probably projects helps a lot. I mean, I guess I should say, or I will say, programs like the extra program are useful if you have, especially if you have physicians who funded it.
So good morning. My name is Jesse Cancer. I'm the president of the Canadian Federation of Medical Students. I wanted to just add the perspective that I think that there has been a change in the paradigm of how physicians.
Can you hear? Jesse, you have to talk a little louder. Sorry.
That is fine. So my apologies for that. So just to start from the top, Jesse Cancer with the Canadian Federation of Medical Students. I just wanted to respond to the concept of bringing leadership into medical education. I think there has been a paradigm shift in how it's happening. I think there actually is a concept in medical education circles that leadership is fundamental to training medical students, and I would say that it exists there. And my response would be that when it comes to interpretation, it's very much a part of my curriculum at the University of Toronto. I finished a 3-hour session over dinner on Friday with students from across the faculty, so it's there. I think the key might be to systems education, though. I think that one thing that we do need to do better in schools is actually trying to explain the complexity of a health system to students. I think we wait much too long for that to happen. By the time someone's practicing, they spent a decade probably learning the wrong things about the health system. So I think all the right notions are there, and maybe just some of the content needs to change.
Great point.
Thank you. Leslie, I'm going to ask you to hold. We're going to try to just keep us to time this morning, and I know you have a strong view on this too. So perhaps I'll just ask the panelists just to offer a closing comment, and then I'm going to turn us over to Frank, who's going to do a bit of interactive polling with us so we can move along to our next speaker as well. Frank.
OK. Je vais revenir à la question de l'engagement des médecins, du leadership, puis de la question du changement culturel. Moi, je pense qu'au niveau des curriculums, et c'est présent dans votre commentaire, c'est très important de donner une expérience du travail différente. Moi, je crois beaucoup qu'on apprend à changer un petit peu la perception de notre rôle, de nos relations avec les autres et de notre façon de faire lorsqu'on a l'occasion d'expérimenter des façons différentes de travailler. Je crois pas beaucoup qu'un changement culturel, ça se fait juste par un processus intellectuel et la discussion. Je pense qu'il faut être mis en situation de confronter différemment les tâches avec les autres et donc de se socialiser professionnellement différemment.
I guess some of the, which is sort of interesting for me looking at this, I was at a CMA event 2 years ago, all physicians, and I felt for them because they felt disengaged in terms of the healthcare system and the systems in which they were working. It was quite amazing, and they've put in some processes to move that along. So possibly what we're doing on patient engagement, we need to do physician engagement. Bring them in to the conversation, bring them in early, and keep them there. And I think that will go a long way of allowing the changes to happen. Because if you feel, whether they are or not, but if they feel they're on the outside, they're not involved in the decision making within the organization, then yes, you're going to have disengagement, and you're going to have the bottlenecks that we see way too often. Have some good friends who are family physicians. Same thing. They're engaged with their patient, but they're not engaged with the system in which they're working in their own city, community, or province. So that's my 2 cents worth on that.
Good morning. I'm Frank Markle. I'm the executive director, of CAHSPR. My apologies, Chairman. Today is Valentine's Day, so one of my roles is to give out Valentines, and I'd like to give a small gift to our 3 speakers to thank them for their presentation.
Thank you. Thank you.
I found that 1 million is too much.
A number of years ago, when I was the president of Trillium Gift of Life Network in Ontario, I remember being told that I liked shiny. You heard about leaders liking shiny. At the time, I thought it was a compliment, but now I realize maybe it wasn't intended that way. But I do still like shiny, and we have a nice shiny toy on your tables. I have one, and each of you has one, so could I ask you to distribute these little white devices, which will let us do some polling. And we'll see now if we can make this work. So there's the first question. These questions are also on paper in your program and also in French, I believe. So if you prefer in French, they're there. The very first question I'd ask you to vote on. You heard John Abbott speak to the conclusion of the Health Council of Canada report that our efforts so far to strengthen the performance of the Canadian healthcare system in the last 10 years have not been sufficient. You heard John talk about our mediocrity in international comparisons, interprovincial variation. So our first question for you to vote on is, to what extent do you agree with this conclusion? And we have 4 choices for you: disagree completely, disagree, agree, agree completely,
Take your voting device and press from 1 to 4 depending on your answer. If you could do that now, please. And in a moment we'll see the results. We're good? Can you show the results then? So you see no one disagreed and pretty much an even split between agree and disagree. Oh, there is one. I'm sorry. one looks like one person maybe disagreed. Quick comments on that vote. Anyone want to make a comment quickly before we move on?
So, Chairman, why did you put that number 2?
All right, we'll move to the second question, if we could. Oh, comment?
Frank, can I just make one comment?
Yes, please, Grant.
Very quick one. Australia has a national leadership strategy. The UK has a national leadership strategy. We've endorsed, or at least have put out the idea of the triple aim plus equity for Canada. That's why they have national leadership strategies and the US does not. We're trying to build equity into the equation, and if we don't have national strategies, we can't do it.
Well, I think that's a terrific segue into the second question. So I'll ask to put up the second question, please. And there you see the second question. It relates directly to Graham's comment. When the Health Council of Canada looked at the goals of the Triple Aim, they felt it important for Canada to add a fourth goal relating to the achievement of health equity. So our question for you is, do you agree with their decision to add that fourth goal, or do you feel that the original 3 goals were sufficient? And you can see again a choice 1 to 4. If you feel strongly that the original 3 goals were fine, vote 1. If you're fine with the original 3, vote 2. If you are fine with adding equity, vote 3. And if you feel strongly that we should be adding equity, vote 4. So vote now, please. And the votes are in. Can we have the results, please? Well, a little more dispersion now, but a majority of the view that we should be adding equity. Comments on this vote? Yes, Sean.
One of the things that's clear in Canada is one of the things that seems to be true about Canada is that a lot of the lack in healthcare has to do with the fact that there are not enough services that are really not healthcare services themselves. So it's support, it's community support. And equity is where that's lost. The fact that people can't have enough resources to allow them to stay home with multiple chronic conditions is one that has to do with the lack of equity. And so we call it lack of equity, but in fact it's lack of a whole part of the healthcare system, which is services that support people that allow them to stay at home.
Very good point. We'll go now to the third question, if I could. Could we have the third question up, please? And John Louis gave you an excuse to go for coffee earlier. I suppose in some ways this vote would do the same. The Health Council of Canada, in its report called Leadership, an Important Enabler for Strengthening the Canadian Health System. The CHLNet report goes even further, I would say, in advocating for the need for stronger leadership. You heard our speakers make that point very eloquently a few minutes ago. We're interested in your response to that question. And the way we've phrased it is, to what extent do you see strengthening leadership capability as the number 1 priority for improving the healthcare system? And again, you have a 4-point choice ranging from strongly disagree, disagree, agree to strongly agree. So please vote now on this question. Do you see healthcare leadership as the number 1 priority? Vote now, please. And the results are in. And again, perhaps more of a spread this time. interesting, but a majority, 43%, agree that healthcare leadership is the number one priority. Perhaps some comments and reactions to this vote. No? All right. Well, oh yes, here we go. Please. And perhaps you could introduce yourself.
Sure. And I'll be giving the talk on clinical leadership later on. So I guess the point is I actually said I disagree. I said number two. I think leadership is absolutely important, but I think we do also have a lot of leaders. The question is, are they all aligned to the same priorities that actually benefit the healthcare system? So, I mean, I work with a lot of leaders every day, and they think we need to have 10,000 more MRI machines, right? So if we follow that leader, we may not get the best outcome. So the question is, we need good leadership, but we also need to make sure that we understand our priorities are united around.
Thank you, Samir. Well, this concludes our first session. I'll thank our panelists, and I'll ask Terry and Mary Jo to come up for the second session.
Okay. Our next engagement this morning gives me great pleasure to welcome Mary Jo Haddad. Many people will know Mary Jo Haddad. I have coincidentally the privilege of serving on her board. She has just finished 10 years of leadership at the Hospital for Sick Children and essentially has done a spectacular job by all accounts from every perspective on the quality of patient care, on building research, on education, and an absolutely spectacular job as a leader. Mary Jo is actually on her way to Qatar, where Sick Kids has a partner project going there this evening, so we're thrilled she made the time today. She's been distinguished in many ways. I'm not going to review all of these with you, but she is both a very, very skilled executive. She has played in the policy pond very actively with the Child Health Network within Ontario, nationally and internationally. And she has played a role as a clinician and basically ran the critical care unit, among other things. So, Mary Jo, welcome. And it's an opportunity to really just have a bit of a conversation together and talk with you and with the audience about leadership issues. So why don't I begin by asking you a little bit about where we just left off, which is, where do you see some of our major challenges are in building the capacity to kind of get to a triple aim type objective?
Yeah, first of all, thanks, Terry. And it's important, I think, for me to set a little bit of context. I really hold some strong beliefs about leadership. And first of all, in healthcare, I think we have such a privilege job to lead in an area where people are incredibly vulnerable and really very much dependent on us. So when you think about leadership and what it's going to take to move forward, I think there are a lot of really important things said. I believe there's a huge talent of leadership in Canada in healthcare. I think many people are in this room today. Someone said that we need to define what are we leading, what is our direction, what are our priorities, and I think that's really critical. If I think about my own organization and the successes that I have had, they're pretty basic framework, and it becomes really interesting when you step back and look at what's worked and why it's worked. And I think first and foremost is real clarity on what's the vision that we have, and that has to inspire people to work in one direction. That's pretty basic. It's kind of management 101, but it really sets, I think, the context in Canada for what do we want to achieve, what's expected of us as leaders, and how do we contribute to the success of that. I think, secondly, critically important, and this has been mentioned, and I put so much weight on this, is on the title of engagement of patients as really true partners in the delivery of care, the way we set up organizations, our processes. It's not, I don't believe, rocket science. It may be hard to do because we're a system that's been very much focused on the providers, but we're here to serve patients. So it becomes, again, a fairly simple approach to a priority. But equally, you can't have engagement of patients if you don't have engagement of staff. So I put a tremendous amount of effort in my own organization because I believe in relationship and in the strength of relationships, but on the engagement of staff, all staff. And I'm incredibly proud of the results that we've had because we put staff engagement as a priority, patient engagement as a priority, and then looking at measuring the results of that for true transparency. So I think if we can really look at the complexity of a whole healthcare system with some of that framework that we all know, I think we would move mountains in Canada.
Just following up on that point, I mean, what is your thought about, again, looking for direction? To what extent in a leadership role do you wait for direction? Do you take your cue from a decision maker, politician, premier? To what extent do you try to work with your own vision to prosecute it? There's a lot of discussion in this country about where the level of decision making is. Is it policy led? Is it administratively led from the field? Is it clinically led? So reflections on this.
Yeah. So
are we waiting for the referee too much?
I think we always wait for the referee too much. I think people wait for permission in our organizations, in our health systems, in our provinces, and nationally. I really absolutely believe that. Change starts from each one of us. And, I'm not an expert in everything. You're not an expert in everything. But coalescing people around the outcomes we're trying to achieve and what we believe because of our expertise is in the best interest of child health or the best interest of healthcare delivery, galvanizing that expertise and that leadership around policy direction and helping to influence those politicians to make the right decisions and the right choice. It has to start from us. It has to start from the ground.
So policy activism by executives as a method, as opposed to just waiting for the call and the direction.
Exactly. So, also you think about, it's really interesting. I'm a CEO of a hospital. I've been asked many times, both by politicians and also by people in other sectors of healthcare, why am I so interested in population health? I am not an expert in population health, but I've spent 40 years in child health. And if you can watch over a 40-year span, children entering the healthcare system, 70% of who shouldn't need it doesn't take much to hit you over the head with. We've got to address the issues at the front line, at the community level, at the population level to change what's happening in our hospitals and the access to acute care, the types of things. We will always need acute care services, always. but we shouldn't need many of them that we're demanding of our system today. So it's incumbent, I think, on us as leaders to pay attention and to be active in all of those fronts.
I'm going to open the floor for questions and comments and challenges momentarily, but maybe just thinking about the pressures that are facing the country. We've got a real, downward trajectory of growth, maybe temporary. The triple aim is an expression of trying to manage in a narrower corridor of growth than we've had in the past. What do you see as the role of leaders in trying to get to this ugly place that most people don't want to talk about, which is the cost and managing the trajectory of growth in costs within the sector?
Again, I think leadership in a complex sector like this comes from many, many, many different levels. So I'm going to resort back to what's my job, what's your job. If we can lead within the context where we have the most influence and really galvanize people, engage people around the change that we're trying to accomplish. So I'll use my own hospital. Within our hospital, I am going to contribute to the success of the healthcare system. If I can do that in an effective way, and I'm looking at the right outcomes and the right priorities as part of a greater system, I'm going to contribute through leadership, improving on our health system. That should also improve the costs of the system. We don't talk a lot about the artificial barriers and boundaries that we've put up, both in leadership between professions, but in the system between acute care and home care and community care. And we still talk about them as separate entities. And I like to think about the continuum from a circular perspective where we're all part of something bigger and we're contributing. And I might walk a little bit into your area, but that's okay because you're going to learn from me and I'm going to learn from you. So it's an attitude and a mindset, I think, as we start looking at costs and cost drivers. I have to go back always to my roots. So, I've spent 40 years in child health. And there's a tremendous amount of evidence that tells us what we should be doing for children. That evidence has been there. It's growing and growing and growing. If we would address those kinds of things today, 20 years from today, we won't all be sitting, well, it won't be us, but people will not be sitting at the front of a room having the same conversation that I've been part of for over 30 years. So I think we have to be bold and courageous and be really clear on what the priorities are for Canada. Where are we putting our energy and focus? And what are the things that we're trying to measure? Are we measuring the right types of outcomes?
Do you think we have enough capacity in terms of training and building leaders for the future? So is it about ideas? Is it about people? Is it about execution? How do we build the capacity?
Yeah. So think about the last 10 years in leadership. There are more programs for leadership and leadership development than there's ever been. I think my wake-up call in my own organization, if I wanted to engage everyone in a vision, healthier children, a better world, and getting them to work not just within the four walls, but with the child health agenda much, much more broadly, I needed the full engagement of everyone, of the scientists, of the clinicians, of the frontline staff, of housekeeping, of everyone who was part of this organization. Put together a leadership philosophy. I defined, with the help of everyone, we talked about what do we mean by leadership? What do we expect? What do I expect of you? What do you expect of me? And then we went out and found a partner to help us put a program together. And the biggest learning, so we've run a program 4 times with U of T and Robin program. I remember the first session when I stood up in front of our clinicians, and these are brilliant leaders in the world in their field. Every single clinician leader at SickKids has been through this program, ran for 4 years. The first time we ran it, I opened, talked about our strategy, our vision, our priorities, the outline of the program, and I didn't participate. It went on for several weeks. I came back at the end and asked them what they learned. And if one physician said this, 10 said, why didn't I have this when I started? This would have been so powerful when I first either entered the system or when I first entered leadership. And there were things about, and this has been said, I think Samir said it earlier, it's about how does the system work? How do decisions get made? Where does the funding come from? If I want to influence a direction, who do I go to and where do I work? So we have this notion in healthcare of, there's the physicians and then everyone else. I don't believe that for a second. I think we're part of something collectively together, and we have to tool people with the right types of education and training and exposure to do the right things. And guess what? They do the right things.
So you've made a major investment in the organization on the people side.
Absolutely.
And getting individuals skilled up to be able to enter and lead, to do leadership jobs.
Right. So they're great right? They're world-leading clinicians, scientists, researchers, surgeons. Leadership is it's not natural for everyone, and much of it needs to be framed within the context of both expectation. You probably, I'm going to get asked this, so I'll address that. Well, it costs money to do that. And we have the same challenges in our organization as everyone else does. And where do you get the resources to do these things? And so I think maybe that's part of what the conversation should be. I knew that if I was really going to do this, I needed to sustain it over time, or else it would have been a flavor of the month. And so I worked really, really hard to find a donor to create an endowment. So I have a leadership endowment. It will never be touched. It will always be there to ensure that the leaders in this organization get access to leadership development.
Fantastic. So let me open it up. Maybe I'll start. Leslie, I'll come back to you about, you're good? Yeah, I think you could jump in on this whole issue about capacity building and how do we get the resources when we're trying to save money. You've just finished spending the last few years getting a hospital budget right size. Now we want you to spend money on training all your senior executives.
Is that working now? Is that working?
Yeah.
Testing 1, 2, 3. First of all, Mary Jo, I think you and your colleagues have really set a fantastic standard for leadership and aspiring leaders. So want to thank you on behalf of kind of all of us. And actually, building on Terry's point, I would actually ask the question, do we really have a shortage of leaders? And you alluded to that, and I saying that you see leaders everywhere. And maybe that what we need to do is we have to kind of blow out of our existing mindset that there aren't a lot of leaders, and maybe there are not a lot of leaders like the ones that we have now, but maybe we're not the ones that are needed. And I'm really looking forward to the next session on emerging leaders, because I think that we've got to completely reframe what we're learning, who we're learning with, and how we're learning in order to unleash the potential that's actually there. And I think we do a great job of stifling what is there. And so I'd be really interested in your comments, Mary Jo, around if you could do something different with your leadership development strategies with that notion in mind, what might it be?
Mm-hmm. So, Leslie, I think you hit on really fundamentally a philosophy of leadership. And so, I've been coined as saying my own organization, I believe everyone has the capacity to lead. It might not be to lead sick kids or to lead the province of Ontario or what have you, but to lead in your practice, to lead as a team member. And if you can empower people and give them the permission to lead and create the environment and the culture where their leadership contribution is acknowledged and is respected, then you have emerging leaders coming from everywhere.
Thank you.
Hi, Mary Jo. My name is Anne Sutherland-Bowl from the Canadian Nurses Association. And very pleased to hear your comments. And it's clear that you've been, and it's well known, that in terms of your leadership, it's been all about engagement. And that seems to relate to another term we've heard this morning about plural leadership. So I was wondering, in your experience when you started down this journey, did you have various groups in the organization or support departments who were surprised that they would be part of a particular vision or a priority that you were going for? And what sort of tools did you give them to be able to say, yes, you are part of this priority or this vision? And have you seen a change in your tenure there, where you no longer get people saying that they are surprised that they're part of your journey, that they know what their role is in working towards a goal?
Thanks for a great question. I think early days, part of setting, I grew up in Sick Kids. I'd been there 30 years. Well, I'd been there 20 years before I became CEO. So the privilege of that is you know what's great and you know what's not great, and you know what you would do differently. So somebody talked about churn and longevity. There's something to be said about if you allow yourself to be open to learning as a leader, it becomes pretty clear what you need to do. Early days, I met everyone in the organization. I spent a lot of time. I was doing some work on values and strategy development, and I didn't hire someone. I decided somewhat foolishly, but I think it's paid back in dividends. I would go out, have a couple of staff members with me, but I would go out and meet with every group. And I remember early days being lambasted by one of the scientists who said, like, what kind of gobbledygook is this? And, I want to just do my science and I don't want to pay any attention to this. I will tell you, 10 years later, he's probably my biggest supporter. Because oftentimes people don't have the time or the inclination to think about their role or themselves in something in a greater context. So it's about setting the culture to allow people to contribute, and to contribute in ways perhaps that they just wouldn't think about. I think the other group I would have to talk a lot about is nursing, and I'm a nurse by background. When you think about large organizations, especially organizations where you're delivering healthcare services minute to minute, day to day, you want the people who are at the front line to be your greatest ambassadors for what you're trying to achieve. So you have to be consistent in bringing people with you. When you're giving them permission to get involved, you want them involved, you have to be vigilant and consistent and constant about it. I used to say to one of my senior executives, I'm tired of hearing myself. And he would say to me, but we're not. So I think you have to check in yourself on what's the message you're trying to get and how are you trying to engage people. And when you do that, over time, it becomes so much easier to lead and affect change. And that change comes from the brilliant people around the leader, because the leader's not got all the answers, and nor is the leader expert in everything. And you need to galvanize and to nurture that coming from your staff.
Michael.
Thank you, Terry. Mary Jo, wonderful presentation.
Can you introduce yourself?
Yeah, sorry, it's Michael Shearer. I'm the President and CEO of Cancer Care Ontario. And I'm interested in picking up on a couple of themes that have come up in your presentation and a bit earlier. One is the issue of overall leadership direction and population health, and you've just brought that up. And you've talked about leadership from within, a group of leaders, collective leadership. We've heard about that in terms of pushing agendas forward. And the anecdote I liked this morning was the speed skater who gave up his spot. And so my specific question is, I'd really like to understand your thoughts on, as you said, Mary Jo, there's probably no one better in the province who understands the issues of population health for children than you. But your board didn't employ you to do that. Mm-hmm. So how do you advance that agenda as a CEO of an academic centre for children's acute services to advance a population agenda? And more specifically, what do you do when those two priorities might be in direct conflict with one another?
Great question. So I think first and foremost, as the CEO of an organization, I think our marching orders are pretty clear. But if you think about one of the most important things a CEO does with their board is set the vision and the agenda for the organization. So let me give you, ours was and is healthier children, a better world. That's pretty bold. What that meant and what I wanted it to mean is that everyone who had anything to do with child health in this organization saw they had a contribution to something bigger. that also gave me the platform to talk about that with the board. If we really believe this, that this is not, my job is therefore not just about the children that walk through the doors of this hospital. It's about having an impact beyond that. And if that is indeed the case in the interpretation, then this is what we need from our researchers. This is what we need from our clinicians. This is what we need from our leaders in the organization. So the dialogue has to be open and it has to, the big picture becomes critical. So leadership and I think really great leaders, you've got to manage for the day. And that's part of why I talked about the leadership development and focus internally has to be first. If you don't have that, you're not going to affect the kind of change you want to change broader either in your population or in the community that you're in. So I think there's a tension point for sure. If I, as the CEO of one organization, spent all my time on population health, I would have a big problem, right? So you've got to, you absolutely have to balance your deliverables and your priorities and a commitment and measurement on where and how you're spending your time. And at the end of the day, it's not just one person, right? So if we're talking about having an impact on population health, we have phenomenal researchers in our organization who do research that, if not shared appropriately and taken out appropriately, it would be for naught. It wouldn't affect the change that we should all expect. So it's a privilege, I believe, to have a research institute. You got to make it work. You got to translate that into care changes or population changes, and our board understands that.
Francine Demir, College of Family Physicians of Canada. So 2 comments and then inviting you to comment on my comments. So the first comment, I guess, is about the previous discussion. And I think that many important things were said, but I think there needs to be an understanding that future physicians certainly are being educated very differently in relation to leadership.
Absolutely.
And I think that there's an important transformation that is currently happening, and that we're going to be a lot more deliberate about this around the competencies around leadership that we're expecting our graduate medical students and the physicians as they enter various specialties. So that's the first comment. The second comment, I guess, is that I think the discourse that we're having right now is very much institution focused. You know, hospitals and the challenges in hospitals are tremendous, and you've given some wonderful examples of what you're doing in your institution. But then there's the other level, which is the whole area of community care, family practices, lots of people who are really at the front end trying to make it work. And I think there's examples of good innovation there with family health teams, patient care networks. But that's another layer. And so I'd be interested in your comments on how you see us fostering that dimension, which is really important at that community care phase moving forward.
2 great comments. Now, first of all, one of the great privileges of leading an academic center is you have young trainees, the new physician mixed with the quote senior physician, and you can feel a palpable change today. I have wonderful examples of brilliant young people who are just hitting the ground running, and you don't have to spend the same kind of time on the conversations about what it takes to be a part of a team, what it takes to lead. So there is absolutely, for sure, change afoot. I think when it comes to leadership and the ability to connect in from the community, I think we have to take down some of the barriers that we currently have to for access to the supports that are currently available in the system all over the place. But they're in somewhat of chaos, and everyone doesn't have access or doesn't know what's available to them. So I think this notion of sharing our resource, we're funded in healthcare as organizations or in the community, and we tend to use our resources that way. I have had a belief that if you can share the resources that are attributed to you to deliver education, to deliver particular services, and someone else is interested, come on in and let's share together. I'm going to learn from you. You're going to learn from me. It's incredibly powerful. And, someone asked me earlier today, there's a lot of discussion right now about sharing our expertise in the world on healthcare. And Sick Kids has been doing that. As Carrie mentioned, I'm going to Qatar later today. People are asking us to give them our expertise here in as individuals and organizations. And a lot of you are all over the world and are all over the country. We need to take care of our own backyard first. No different message than you take care of your hospital if you're the CEO of a hospital first. You develop the leadership, you engage people, and then it just rolls out and it gets bigger and broader and bigger. So I think from a community perspective, it can be pretty lonely. I know that when you're the one provider, a provider of N or any small team, access some of the resources that are available to you, and it doesn't ever hurt to ask.
Marvelous. I've got 3 people who want to ask questions, so I'm going to do the unusual job of asking you to put your questions or comments immediately and then ask Mary Jo to respond in a cascade, if that's okay. So Wendy, Lee, and Brian.
Well, mine's more, hi Mary Jo.
Could you introduce yourself,
Wendy Nicklin, Accreditation Canada. Thank you very much. I've known Mary Jo for some time, and it's been amazing the contribution you've made, and appreciative for the impact on all of us. Basically what I'm hearing, and it's more reflective, is that focus on the patient journey. Population is essential for organizational success, because otherwise how do you plan for 5 to 10 years? And your tenacity and commitment is key. And I would wonder, what would you say are the 2 or 3 values? I'm not hearing comment, as much, not from you, but generally. What are the 2 or 3 values that have enabled you to maintain your commitment and success?
Can I go?
Yes, please.
Okay, so 2 or 3 values.
Sorry, we're going to take all the questions if we can do that. So
I got to remember them all.
Because otherwise, I think we'll wind up. I'll prompt you, Lee.
Thanks very much for your remarks. One thing it's triggered for me is you made a comment that when your clinical leaders went through the leadership training, they came out of it, and one of the first things they said was, I now understand how the system works, and that'll allow me to lead better and advance things better. And, it strikes me that should actually be a core competency of our clinical training at that point, and not reserved for leaders. And I actually, if I reflect on my own experience training years ago as a radiation therapist, I didn't know how radiation oncology fit into the broader scheme of the system. And I went and got education to learn that. But I actually think that should be something we focus on. If we want to have plural leadership and we want to be advancing things in collaborative ways, we've got to have people in the system that understand how the system works. And then leadership, I think, should focus on how do you lead across that complex environment. So I just,
Sorry, Lee. I didn't mean to cut you off. Brian.
Brian O'Rourke from CAHSPR. Mary Jo, I love that vision. Healthier children, a better world. And what a wonderful vision for Canada that would be. That would encompass both fitness and education and housing and as well as healthcare. So bringing that back to leadership, you've done some wonderful things within Sick Kids. If we were to take that beyond what you've done there at Sick Kids to beyond Sick Kids, to beyond Toronto, beyond Ontario, to a Canadian leadership strategy, and some of the things you've heard this morning, what would you do to try and, can we do it from a Canadian perspective, or is it more a local issue?
Okay.
Can you remember?
So I can remember. So on the values, let me start on the values piece. I'm a leader who has spent a lot of time thinking about values, my own personal values. I'm very grounded and very principled, and I do this thing about you wake up in the morning, you're all by yourself in the mirror, there's no one else there. You got to stay true to who you are. So I think integrity is critical. I think collaboration, a value of collaboration, true collaboration. So when we're talking about collaborating with families, it's about hearing what they have to say to you, and sometimes it's really hard. And when we have failure, and owning that and wanting to do better because that's why we're there, that's really true collaboration. And collaboration means at every level. And I'm a big believer. I value that tremendously. And I think the third one I would say is the commitment to learn and grow personally, because every exchange is a learning experience, right? Everything you do, you should ask, what am I taking back from this? How am I being better? So that's the whole notion of self-reflection and the ability to take that and share that with someone else. I think, you talked about education, and I can't disagree with that at all, but I think we have to be very sensitive to, we want phenomenal clinicians. We want you to be the best oncology radiologists you can be. And sometimes we overburden people with so much information. Are you really going to take away from in your early training how the health system works? You should have a framework. You should have some understanding of it. But I think we owe it to ourselves. And clearly, it was my greatest takeaway. We need to, and so now we spend a lot of time early days, not just with physicians and clinical leaders. We do in our orientation in our hospital, but I shouldn't have to do that. People should be coming in, understanding what's their role in this greater family of service providers. So I agree with you. It needs to be more fundamental in the way we do curricula, but we own it as well from a system perspective. So Brian, taking all this up a notch. I mean, again, when we're talking about Canada, if I were to ask all of you, what's our vision for health in Canada? What's our vision for our child health in Canada? We have to speak at some point, at some level, with one voice. And we have to be really clear on the direction that we're heading in, so that leaders like me and you are bringing whoever we're leading to that accomplishment, to that goal. And I think sometimes we make things too difficult. We make them so onerous that we never move in a direction. And we need to celebrate what we do well. That we have phenomenal leaders in this country. They're all over the world. I had this wonderful opportunity 2 years ago or so to go to Israel. It was my first time. I was with some of the Canadian healthcare leaders in this room. I was so blown away personally by the accolades that we were getting as Canadian leaders and the contribution we made halfway around the world. We need to celebrate Canadian leadership. We beat each other up. We beat ourselves up. Our governments beat us up, and we beat up our governments. There's something very wrong with the attitude and the mindset that we have. This should be a very positive thing. And I think that's part of the strategy when we're talking about leadership and leadership development. My greatest fear, my greatest worry is that we're taking away the excitement and the enthusiasm from young people. And we can't ever do that. So we need to give ourselves a bit of a shake and start encouraging, mentoring, coaching for positive leadership going forward.
Fantastic. A very good point to end. Mary Jo, thank you very much for spending the time with us. Please join me in thanking Mary Jo. I think Frank has a Valentine gift for you. I'm just guessing.
I feel like a very lucky man at this point because I get to give Mary Jo a Valentine. Mary Jo, I'm mentoring students in the health administration program at the University of Toronto these days, some of whom work at Sick Kids, some of whom are nurses working as managers or project leaders. And when I try to encourage them to think that they can go very far in their careers, I want to tell you I talk about you. So, and today was just a brilliant example of those skills that you bring to our system. We're very lucky to have you in the system. I'm giving you my Valentine. So I'm back with my toy, and you can all pick up your toys now again. I wrote a question following Mary Jo's presentation. If we could put the question up on the screen, please. A number of people, including Michael, alluded to this question. I think the people in the audience said it better than I did, but here was my attempt at it. We know Mary Jo is very proud of Sick Kids. She would argue, I'm sure, that the Sick Kids is as well positioned as any player in the system to move forward the goals of the Triple Aim. But as we've heard, across the country we have other organizations, other mechanisms for doing so. Regional health authorities now in most provinces, even one province that has a provincial health authority. You know which one that is. And of course, organizations focused on particular disease entities. Another example of a different structure. So your chance to vote now is, of those four approaches, which one, if you had to pick one, and I'm going to make you pick one for the purposes of this voting, which one do you think will be the most effective in achieving the goals of the Triple Aim? If you believe it's traditional organizations working cooperatively together, vote 1. If you think it's regional health authorities leading a cooperative approach, vote 2. If you think it's a strategy led by a disease-oriented organization, vote 3. And if you think it's a provincial strategy led centrally, vote 4. So vote now, please. Les jeux sont faits. The results are majority for regional health authorities and second largest vote for provincial health authority. Thank you for the voting. Thank you, Mary Jo and Terry. And I'll invite the next panel to come up. I will explain at this point our next panel session, which deals with the role of clinicians as leaders, was originally to have been moderated by Stephen Samir from CFHI. Unfortunately, Stephen was caught with this bad weather and was not able to get here. So I've prevailed upon Bill Thal, one of the key organizers of the conference, and Bill has very graciously agreed to moderate this session. So welcome, Bill, and thank you.
Thanks very much, Frank. Is the microphone working? Perfect. Could I invite all our speakers, Bobby Joe and Robert from Emerging Health Leaders, could I invite you up here as well? And while we're at that, I mean, this is great. Come on up. I'd like to thank particularly the College of Health Leaders of Canada, Canadian College, for helping us, for the first time, get the node leaders from across the country for Emerging Health Leaders in the same room. So just so you know who they are, could I ask the Emerging Health Leaders, apart from the two on the stage here, getting to the stage, to raise their hand, just to let you know where they are. Okay, Brian, you're not an emerging health leader. Come on. So that's great. Thank you. And I'm glad you're here. This purpose of this, I guess to go back to where Terry began, he identified at least 3 or 4 dimensions of leadership that need to kind of come together to move the agenda forward. He talked about political leadership. He talked about executive leadership. Talked about patient leadership, and I'm very glad to see so many representatives from Patients Canada in the room today. And he talked about, importantly, clinician engagement. So we have one presenter this morning and 2 respondents from the Emerging Health Leaders to really get into that a little bit more in terms of what's required in order to effectively and in a sustained way engage clinician leaders. And this isn't by accident that we have a physician to kick things off, and a nurse, and then, have you graduated yet?
Not yet.
Just about? Okay, good. Bobby Joe, Health Administration from Dell, right? So we're going to ask, and we haven't had a chance to talk yet, but 10, 15 minutes, is that your understanding,
20,
Samir?
Yeah.
20? Okay, so 15, 20 minutes, Samir. You have a very, you have a short snapshot of Samir's impressive bio in your package. Royal Roads, or a Rhodes Scholar, physician, currently with the director of geriatrics at Mount Sinai, and University of Toronto University Health Network, as well as an appointment with in terms of the Ontario Senior Strategy with the Ministry of Health. Is that correct? So we're going to go from a discussion around the importance of leadership in advancing child health, which we just had, to the importance of leadership in advancing the health at the other end of the life spectrum. So I'm going to turn it over to you first, Samir, and look forward to your remarks. Thank you.
So thank you very much, and it's a huge honor. And as the sessions were going by, I realized that when Jeremy just said, "Would you like to give a talk?" I thought it would be a straightforward, intimate little chat, and I realized I come with a lot of an opportunity here to really share amongst an august group of people a little bit about my views and reflections on a career in clinical leadership. And it's timely because I have to do my 3-year review at the University of Toronto. So this weekend is going to be spent writing a letter to the review committee about what have I been reflecting on. So this is actually a wonderful experience for me to reflect on my aspects as well. So I just want to take you a little bit through my journey, because I think it's always helpful to understand, what have people's experiences been, because I think there's a lot of similarities when I talk to other clinical leaders about, how did they get involved and what has their journey been. And I always think that whenever I talk to a colleague who, whether they be a physician, a nurse, a social worker, I think we all grew up as, when you're young children, wanting to help people and make a meaningful difference in that way. And I started when I was 12 years old, after I went on a trip to India, and, finally witnessing, grinding poverty that I'd never seen, saying, I need to do better. I have to make the world a better place. And that's what started me on a whole career in advocacy around starting the environmental club at my school, to raising money for World Vision Canada, through getting all my students to fast for 30 hours, my student colleagues, and to raise money and awareness about some of the global issues at hand. And it was through those experiences that I actually, World Vision sent me over to Senegal, West Africa, when I was 16 to actually work and do things. And they said, what do you want to do? And I said, can I shadow the physician? And it was an incredible experience, because here was a physician who had realized that by taking the huts where he delivered children and wrapping them with pages out of magazines and putting a plastic tarp on the base of the floor there, on the dirt floor, he was able to cut child mortality rates in those communities by half. I mean, Mary Jo was talking about making a better world, and this was just very simple things where you could see what was making a meaningful difference. So that was the time at 16 when I said, I want to do a career in medicine. This is how I feel I can make a difference like that individual. I've been very privileged because as I started in medical school, I then went and worked. One of my first experiences, having born and raised in Winnipeg, was I had a large interest in Aboriginal health, and I had many friends who were from First Nations communities or Aboriginal peoples themselves, Métis. And so I actually was able to work with clinicians through the University of Manitoba when I was a student at Western, and got to live and work in a First Nations community in northern Manitoba. And that was an incredible experience. I was there to do my research, but I started asking questions about health equity and how do you deliver services in an equitable way to a community. And I was really lucky because I had clinical mentors who basically said, you have a lot of great questions and you have a great potential to do things for others. And so they asked me, they said, you should apply for Rhodes Scholarship, mainly because he said, as a young clinician who's very idealistic, you'll get a voice. People will actually listen to you because, they won't know your name, but they'll hear Rhodes Scholar, and therefore they'll at least hear what you have to say. So make sure you have something important to say, right? And when I went to Oxford, I was very privileged to work with a mentor who I just saw 2 weeks ago. I see him annually. We email regularly, Charles Webster, who is the official historian for the National Health Service. And on my very first meeting with him, he said, to whom much is given, much is expected. He said, you've led a life of privilege in the sense that you're privileged to be here on this scholarship with this opportunity. And he had worked with Roy Romano around the creation of the Romano Report. So he had a very good understanding of the Canadian healthcare system. And he said, our job over the next few years and your job in the future is to use these opportunities to figure out how you can make meaningful change. And you have a great responsibility to do so.
So he very much wanted to keep me in the world of publicly funded healthcare, because his former student is actually the head of United Healthcare and in the U.S. But he said, you have an enormous chance to make a difference. So really along that journey, you also will find your passions and so on. Because I was a physician, I was actually destined for a career in gastroenterology. And it was while I was at Oxford, Charles actually said, well, you're very interested in working with vulnerable populations. We don't have First Nations people in England to do further work with, but we do have the elderly. So he said, concentrate on this population, learn about this, because when we think of a lack of clinical leadership or a lack of expertise, it really occurs in this area, which is going to be one of our greatest, challenges. And he said, this way you can help multiple populations around the world and make a difference. And at that time, my grandfather started struggling with dementia. And I actually, as I continued on with my medical training and so on, and by becoming a geriatrician, I started realizing actually how much I could actually help in his situation when we come from an entire family of physicians, and yet none of my colleagues in India, none of my family colleagues in India are all physicians, and my cousin's just off to the side there who's also a physician as well, but none of them knew what dementia really was, because we don't really talk about it in India, because we don't really know about it. So going back and actually realizing what you could do allowed my grandfather to age in place and gave him the dignity to die at his own home, but also made me realize how powerful education, leadership in the realm of geriatrics could actually be. That's where I found my passion. So the one thing I always say to people is to, you really need to then, once you find your passion, acquire the skills you need to succeed. And I think for me that was really important, because skills come in different ways, right? Depending on, as we've heard today, part of it as a clinician is understanding how the healthcare system works, right? If you just work in your practice and see your patients, and I have a lot of colleagues who say, I don't want to think about anything else, I just want to do my patient care. But then they come to me and they say, why does this work like this? This is just so useless. I can't get my patients the care they need. And I said, well, let's talk about how things work and how we could actually change the system together. And same, so it's important to actually have those skills. And I was just lecturing the first year medical residents at U of T 2 weeks ago for their geriatrics half day, and they said, why has nobody actually taught us, when we're working all the time in the hospital, what are the community services, how home care works, how that, because our patients come from the community, they want to go back home, so we need to help them out as well. So the key is, it's important about acquiring the skills we need to succeed, because if you don't get those skills, then it's hard to understand that. And it's understanding, how do you write reports? How do you write briefing notes? I remember when I got my first consulting contract, someone said, will you consult for us? I said, sure, it's good money, but I'd never worked as a consultant before. So immediately I called all my friends who are consultants and said, what do you do? And they said, use a GANS report. They sent me charts. They said, use this. I actually found a website online which actually taught you how to be a consultant, and it was great. They thought I had worked with, all the major firms forever. But again, it's about being resourceful, leading on your networks. And I actually do have skills now, though, so please don't think I just fly by the seat of my pants. So a lot of people always ask me, so if I follow your route, is that how I get to where you are? Or what degree should I do? Do I do the Master's in Health Administration? I was just talking to the colleague next to me about the decision I made to go into geriatrics versus, public health and so on. And the people always, are always thinking about, when they have that vision in mind, what exactly is the path that I need? And I'm sorry to report to everybody, there is no right path to get there, which is actually a really good thing too, because I think it reinforces that there's no right way to get there. But if you have your passion, you start acquiring your skills, and you look at those opportunities, I think that's actually how you can start getting to those areas that you need. So I always reinforce to people, there's no one right way, but I think the key is that, it's our journeys and those opportunities, and looking for those opportunities are the way to move forward. So the one thing is, if you read, Cotter's work on leading change, or you look at these things, and actually, And I hope everyone here has read Machiavelli's The Prince, because one of the things that actually resonated the most with me in his book, was the particular aspect about, the prince always meeting opportunities, that every one of us meets opportunities every single day. And what he was saying was what works between those who are successful and those who aren't successful are those who understand the opportunities in front of them and make the best use of them. And especially when you're using them for good, then, you're unstoppable in that way in terms of achieving what we're collectively wanting to achieve here. And so I always say, find your burning platform. How are you going to get people's attention? And the thing that Charles Webster told me in 2001 in his study at Oxford was, he said, nobody really thinks about aging and geriatrics right now. But he said, once you graduate and you qualify he had it all planned out for me on day one. But he said, once you graduate as a geriatrician, I was still going to be a gastroenterologist at the time. But he said, in 2010, that is the year the baby boomers start turning 65. And that's finally when people are really going to take notice and do that. So we know. 14.6% of Canadians are 65 and older, and they account for half of our health and social care spending. And we know that our older population is going to double. The 85 and older population is going to quadruple. And everyone sees this as a challenge right now, but an opportunity for a clinical leader, an opportunity for all of us, is to also see the opportunity. Because if we can see the opportunity in this, then you have an opportunity to lead and an opportunity to do better. This is the data for Ontario that, again, shows that burning platform, what all the CEOs are getting very excited about, which basically shows that 42% of hospitalizations in Ontario are by those who are 65 and older, and most of our bed days in Ontario are counted by those who are 60 and older. So it was very easy to get the attention of CEOs, but still not every hospital CEO thinks that geriatrics or the care of older patients is a priority. Some of my CEOs that I work with are still more obsessed about transplants and other things. Yet, if this is not your core business, then it's important. But the key is, so find those leaders, find those CEOs who actually share your vision as a clinical leader so that you can move forward. And this shows the data, again, in my region of Ontario, Toronto Central, where again you can see the majority users of the system are those who are 65 and older. So the burning platform is this, and that's showing that right now this is actually how we spend our healthcare dollars in Ontario by age. And you can see this is the difference, what it's going to look like in 2030, and this is the moving target, the $24 billion differential between what we spend today versus what we'll spend in 20 years, mostly to meet the needs of an aging population. Okay, so we all know this, right? Everyone in this room knows this. We get that. But again, is that going to inspire people to do something differently? And that's why it's always thinking about how do you actually get people's attention? Because again, I would always see as a leader, people are always thinking about, we know this information, we do that, but it's not getting people motivated enough. So how do you actually get people's attention in particular? And I think it's the key of the opportunity about how do you shape your argument? How do you shape your opportunity to make that change possible? And so it was really important because I actually, it's no secret, because he makes it absolutely no secret that one of my patients is a former premier of Ontario. And so we usually spend an hour together in follow-ups. He usually says, okay, he said, are we done now? Because now it's my turn to help you out, basically, in terms of giving me advice. And I gave him a call because I said, so I have the premier's office has called me and asked me for advice about aging. What do I do? And he was amazing because he said, let me tell you how it works, right? He said, if you have 45 minutes, if you have an hour, with somebody to talk to them, and that's one of the questions that we have, the discussion questions. If you have a chance to make a conversation, make sure it's a point that, will get their attention, but make sure it's a point that actually shows an opportunity where how you can help them lead. And so these are the data points that I have to show, because people always think that when we think about the aging population, we think it's sick, it's old, and it's using hospital services. But the slide I like to show, in the interest of time, I'm just going to go through these more quickly, shows that the majority of people are actually not big users of hospital services of the aging population. Most of them are actually healthy and well in particular. It's only a small proportion are consistently extensive users of services. We also know that what defines them are these three issues: multiple chronic health issues, social frailty as a major issue when we're talking about those social determinants of health, and also functional impairments as well. So are we targeting these issues and making sure we have that? that. And we know that this matters because when you look at the fact that only 10% of older adults account for 60% of our healthcare spending amongst all older Ontarians, then it's really important to think that we can do better for that population. And that really, we know the burning platform, but this is really the opportunity for change, especially when we know that 50% of the healthiest individuals only account for 6% of our healthcare spending for those who are 65 and older. So I like this slide because it really shows us again when we start educating ourselves. Very few patients and very few members of the public see a slide like this. Very few clinicians see a slide like this. And I like how the Minister of Health likes to view this slide because this is how we actually divide our healthcare pie in Ontario. But my minister always says to me, this is our expression of values. Because as Canadians, as Ontarians, this is where we actually place our value with our healthcare dollars. So you can see how much we value certain areas like community care versus long-term care versus acute care. And the opportunity moving forward in our society is, what is the leadership that's going to take to make sure that our expression of values or the way we fund is also reflective of our new values in particular. And so the key that I've always been espousing is the fact that, yes, I work out of a hospital, I'm based out of a hospital, but we know that there are alternatives of care closer to home in the community that are actually not only cheaper, but they're actually in line with what people actually want. And so we know that other places in particular have been able to avoid building any new long-term care beds like Denmark over 20 years by actually investing more in home and community care. And that was the goal that I wanted the Ontario government to actually see. As a clinician, as a geriatrician in the hospital, I knew that more of my patients, more older Ontarians would be able to stay independent and our healthcare system could stay sustainable if we actually made that transformational shift towards more home and community care funding. And that's what we've been seeing. While hospitals have had to have a 0% increase over the past 2 years, it's meant that this past year it was a 6.2% increase in home and community care. Again, that shift which has been absolutely important. So I've been working on something called the Elder Friendly Hospital. And again, it's a way of thinking about how do we transform the care that we're doing. And it was really about working at a hospital. The reason I chose Mount Sinai to be my base, I work at UHN as well, is because they really have an emphasis on clinical leadership. It's physicians and nurses who actually lead the ship at that hospital with talented administrators. And many of us have to do administrative roles as well. But that way we get to shape the agenda. And my agenda was developing what we called our acute care for elders strategy that really focused on that team approach and really emphasized clinical leadership. And our strength also resolved on relying on system partnerships, not only within primary and home and community care, but across the GTA, making sure that we really functioned as Mary Jo said, as a system. So it's remembering that with clinical leadership, it's not about you, it's about the team. And the more you bring people into that team as those coalition of the willing, it's absolutely important. And Mary Jo talked about that circle, that continuum of care, and that's essentially what we've done. Not just services that we do in the emergency department or the inpatient ambulatory, but we spend just as much time working with our community partners to build community interfaces to say, how do we better support as a hospital so that our patients who come from the community can return home? So the key is that while we say that stories trump data, data provides solid and lasting evidence and why it's important. So the one thing that I was taught very closely by my mentors was to make sure that you evaluate what you do and articulate what you do as well. And so this is the data. We're treating 30% more patients than ever before. Our lengths of stay, though, have been cut. Our ALOS-ELOS ratio has been cut. The percent of patients that are returning home is increased to 79%, better than our regional average. And we've actually closed beds because we can't actually keep them filled in that way. And when we actually look at our readmission rates, our catheter utilization, our quality of care, it's improved, and our patient satisfaction has continued to increase, and this saves money. It's been a win-win. It's that triple aim that we really emphasize. And that's the key. This data has allowed me that in a 0% budget environment, my CEO said, well, I said, look what I've saved you now. So I said, I have a little bit of an ask. And he can't really say no, because absolutely, I've delivered on my pledge to deliver better quality, but also save dollars, because I know what's his priority as well. And so we're able to move it forward. So finally, really, share your successes. Make sure people know what you're doing well. A good a good mentor told me, make sure you check in with your CEO. Make sure you check in with the leadership within your healthcare system to tell them what you're doing well, and share it with your colleagues as well, because those successes can become the successes that others will rally around, and that you can cooperate with as well. But also acknowledge your failures. Failure is okay, and that's absolutely important. But make sure you learn from them, because if you don't learn from your failures, then you're not going to be able to achieve more successes. And then finding a good balance really is around not finding a balance between your successes and failures. You want to have more of an imbalance on that piece, but also thinking about yourself as a clinician and thinking about finding a good balance between your work that you do as a clinician in terms of what you do clinically, what you do administratively, but also your personal life as well. So remember, I like this. I was finding bad clip art all over the internet, as you can tell. I had fun. And this was I looked on Google Images and said, the cheese stands alone, what can I find here? And this is basically, if it's about you, you're missing the point here. I learned very much from the beginning that really, if this is about what you're trying to achieve, this is actually how you move the bar forward in a much more successful way. And so that's a key lesson that I've always remembered, to always celebrate my team members and make sure. And I think you can hear very closely. This is Mr. W, my patient, by the way, who is turning 104 on Monday. And Mr. W, as one of my patients, as long as many of the mentors I mentioned to you already, I can tell you have absolutely been worth their weight in gold, because it's absolutely important to have people that you can rely on, people you can share, people who can actually give you the lessons they've learned. So as all clinical leaders, I say, find your mentors and cherish them and work with them. Thank you.
Thanks very much, Samir, for sharing your leadership journey and the importance of mentorship from the beginning to now, including, I thought rather interestingly at the end there, patients as mentors, right? We now want to move on to, and we'll come back for the question and answer period to maybe probe a little further in terms of your experience in terms of clinical engagement, enablers, and barriers, or I think I heard Leslie talk about stiflers or something along that line. So we're going to invite, at this point, Rob, we'll invite you up first to give maybe a 5-minute response in terms of, from your perspective, what are the key enablers, key barriers to engaging clinicians, emerging leaders, nurses, physicians, and then we'll follow that by another 5 minutes from you, Bobby Joe, and then we'll open it up to questions. Okay, so Robert, over to you.
Yeah, happy to be here, and thank you so much for the invitation. It's a pleasure to have the opportunity to actually respond to it. And I think the question that was posed to us was that about how important is clinical leadership, and it's a tough one for me. I think it's clearly, yes, clinical leadership is obviously important, but so often when it's phrased in opposition to clinical, non-clinical, I think really leadership requires perspective. And I think that is one of the things that Samir talked about in his presentation. What does he have that he can bring to government, and understand what he brings to the actual table, and what can they understand from your insight. I don't think it's a clinician is the answer for leadership, or a non-clinician is the answer. It's perspective is what we really need. And I think on that last note, patients also provide a really important input to the actual perspective that we need to take in our leadership vision, in our setting up. Where do we want to go, and how do we actually get there? And I think for myself, speaking about my own clinical leadership journey, I started off being a student who was very interested in technology. For those of you who don't know me, I'm very kind of passionate about digital tools and how we can use social media to engage healthcare providers and patients. And I had the opportunity to speak with different executives on the University Health Networks trip, and they'd listen to me, take my input, and then kind of pat me on the head and say, that's great, you go out and you do that, but where's the evidence, and how am I going to fund this? They were thinking about completely different things that I, as an emerging leader, had no ability to fathom. And I joined a board 3 years ago, and my perspective has fundamentally shifted. I understand what pension liabilities are. I understand what a cash flow statement is, an income statement. these things, I didn't have that type of perspective. And now that I actually have that perspective, I'm much better able to actually have conversations with middle managers and senior managers about those ideas that I have and ability to contribute to meaningful ways to get projects started because I understand their perspective. And I think that's a big way that we can also address barriers from those types of conversations. And to actually get clinicians involved is to help share that perspective. It's one of the things that an audience member commented on to Mary Jo in her presentation. And I think sometimes when you share perspectives, they may be different. And there is a role for the leaders to actually set the direction for where we're going. But at least when you give them the opportunity to understand the perspective that you have and to have authentic input into the process, it actually creates an environment where they can get supportive and get behind and support your broad initiatives and also point out where there might be a need to kind of influence and change certain types of things. Clinicians and frontline workers are much better suited to pointing out what they need to better deliver care. And sometimes when the decision-making, the dialogue happens without their authentic input, we put into place mechanisms that can measure wound care. I can think of documentation and things that get you the metrics that you want to measure and the things you want to improve on. But the way that they end up being implemented, it takes the time out of my patient care. It takes the time that I actually get to spend turning and repositioning the patient, which is what we're trying to measure and lower. So we need those actual authentic input processes in that kind of leadership journey. And I think capacity and skill development is a big thing that is the barrier to it, both from a clinical and non-clinical perspective. And I think when we think about healthcare, one of the greatest opportunities, I think, is thinking a little bit beyond healthcare proper. But how do we get engineers, people that are computer scientists and thinking about working in Google and Facebook and get them really kind of engaged within the healthcare kind of challenges and see outside of our hospital walls as being part of the solution to the problems within healthcare. As was said earlier, it's not just about growing our acute care services to be able to better address the challenges we're facing, but what are the things we can do in creating healthier communities and healthier environments so that we get less people coming into our doors and we're creating a more healthy society. And with my last kind of 30 seconds, I guess I'll just briefly touch on how are we going to get there. And I think technology to me is a really interesting opportunity. I think it's great when organizations have internal learning and support structures, but I think why can't we take those and share them broadly beyond our actual organizations? And in Ontario, that's where I'm from. I know it's not the case everywhere, but we often spend in thinking programs within an institution. But why on earth would you need to have a leadership development program and hire and pay to develop it within one institution when it could be shared more broadly? And yes, the actual coursework and the staff time, you're going to pay for that within your own wall, but how can you use technology to at least take that content and spread it out a little bit further? And I think the other piece that was talked about is mentorship and the relationships. And I think that's one of the things that Emerging Health Leaders is really trying to do is create the opportunity for us to come into contact, to have the dialogue and the shared conversations so that we can gain that perspective and that insight. And sometimes it is through a meaningful relationship that's ongoing. And sometimes it's just that 1 hour conversation and input that we will get from leaders like yourself that really can make the difference for Emerging Health Leaders and where we set our course.
Thanks very much, Rob. And Jo, over to you.
Well, first of all, thank you very much for inviting us here. I know all the Emerging Health Leaders individuals are very grateful to be at the table, so thank you for the invite. Excuse me, sorry. I am going to refer to my notes a fair amount because in preparing for today, I relied on a few mentors and colleagues and their input in order to make it a little bit more than just my voice. So the first question that we were asked was, how important is clinical leadership? And as I myself come more from a business... Is that better? Okay. I myself do not have a clinical background. I come from a business background and then went back to school to take a Master's of Health Administration. So I relied a lot more on those mentors for that answer. And they said, so I asked Chris Power, the CEO of Capital Health District Authority in Nova Scotia, and Alan Horsgrove, the CFO of the IW Health Centre, and Robert Armstrong, who's an executive director in HR at Alberta Health Services, for their input. And in kind of collectively what they said to me was, if you think of the health system as a person, how can the head be doing something without thinking about whether their feet are ready to walk or not? So we're not separate, clinical or non-clinical. We're all individuals doing the same thing. We just have a different role to play in that overall goal as a person or as a system. So Alan, who's a CFO, said, how can I make decisions without knowing what works clinically? I can't make anything without consulting them. And Rob said to me that how will he be able to do anything from an HR standpoint if he doesn't have the clinician managers who actually roll out the programs and have the buy-in? And Chris Powers said to me that often in her mind that sometimes clinicians fail to understand how they contribute to the bigger picture, but their voices are very important and need to be heard and embraced so that the different programs are successful. The next question that we were asked was, what are the challenges in growing clinical and non-clinical leaders? So I referred again to my mentors and colleagues and looked at a Health Association of Nova Scotia report. This report was produced in June 2012, and it said healthcare is a complex environment. There's looming retirement and lack of succession planning. Most organizations do not have a formal leadership model. That may have changed since 2012. There's the time that's required, the recruitment and retention, funding and accountability. Rob said to me that sometimes there's lack of role clarity and expectations, because if you had to have clinical skills and then all of a sudden you are required to have more business skills, you need to put a budget together, as Rob was referring to. You've never been taught those things, and now all of a sudden your role has changed. How are you going to go and do these types of things? So there needs to be better prepared for those types of skill sets that are required. And then when I asked Alan, so again, he would come from a CFO perspective, he would say, you need the cha-ching. You need the resources to grow leaders. And you also need to have materials and courses and have that leadership development. And then he also put in a plug that he's writing a book. Then also he said, and this is interesting, I don't know if it applies across the country, but marketability. So he said there might be a possible perception within the medical and clinical providers that they don't see leadership as a positive thing, or that they actually want to become a manager or an administrator. I don't know if that's true for everybody, but I thought that was an interesting point. And then compression, he said maybe there isn't the difference in pay scales that encourages people. So I'm going to leave this thought. I'm sorry I'm 7 seconds over, but I noticed there was talk, and it's been a reoccurring theme here, to have a program on succession planning, a national strategy on succession planning. And it occurred to me that we could do some really quick wins. So the first thought was, everyone here is, I assume, in a leadership position to some capacity, and there have been things along the way that has either helped you get there or not helped you get there. So this isn't something new that we're facing. We're just facing it more on a mass scale because we're reaching a point where there'll be many more retirements. So I encourage all of you to think about what worked for you and what didn't work for you and pay it forward. Pass that along to the people who you see coming up through the ranks. And another thought was something that's very simple, is job shadowing. EHL Nova Scotia is doing a program where we've identified 18 leaders, including the deputy minister, who's agreed to have someone come and job shadow them for a half day, and Krista Connell, who's here in the audience. Thank you very much for believing in our crazy ideas. So we're just having them, our members go and job shadow for a half day so they can see what it's like to be in those positions. And another quick win, an easy thing to do, is invite people to the table like you've done today. Inform them. Give them information. Some people might not want to step into those roles because they're just not as informed as you are. And ask for their input. And that's it for me. Sorry for my extra 50 seconds.
Oh, I think it was worth the last three tips there on quick wins. Thanks very much to all three of you. Just a time check. We are running over time. We're going to take it to about 10 or maybe maximum 15 after we got a 10-minute late start. So we're going, and while I was listening, just so you know, there are 3 sort of note takers for each of the 3 organizations. So there'll be a high-level summary of the notes coming out of today's session that I believe will be feeding back to everybody who is in attendance, and for those maybe on the line as well. So I'm going to open it up for questions. And Leslie, I hope you don't mind, but I'm going to start with you. You said you were really anxious for this session to happen, and get your reaction to the 3 tips. Let's start there. The 3 tips that Bobby Joe has left with current senior leaders on what they can do to help future leaders.
Thank you. It's Leslie Thompson in Kingston General Hospital. I thought you guys did a fabulous job. I love the 3 suggestions. I'd offer up a perspective on them, though, that would like to hear from you. I worry that not just about us paying it forward, actually we need you to pay it forward, because we go into these fairly traditional models. I know we have value as mentors and people with experience, and all of that matters, but we also need to be learning and partnering with emerging leaders and unlocking our own assumptions and behaviors so that we can be better leaders with you. And I think there's still a very paternalistic view of leadership development that is very similar to how we work with patients. So what we've been adopting in our organization and many others, Patients Canada and others, is really embracing the moving from the mindset of doing for and doing to and doing with. And once you have the mindset of doing with, not only with engaging patients, but with engaging our leaders, I think the things that we would be talking about in leadership development and the things that we'd be working on with you would be very different. We come up with the brilliant ideas of what we think you need to know, and often they're not so brilliant because they're not as relevant. And I am most inspired in my career by the kind of 8 little sessions I do each month, 15 minutes to an emerging leader, anybody who wants to spend time with me. I learn and get totally jazzed by what people are thinking. And so I'd like your sense of what needs to happen so that you can pay it forward and you are the force of leadership change, as opposed to thinking you have to learn everything from those of us who have been around for a little bit.
So balls back to you, Rob, and Bobby Joe.
For me, I think that it's a high compliment to Leslie's thought leadership, that you're so open-minded in it. And I think it is something that we have the opportunity to contribute. And I would encourage leaders to be not intimidated, but I think we do have things to share. We want to. The best relationships and mentorship that I've been part of are usually reverse mentorship, because it allows, as small as it is, if I'm helping someone fix their PowerPoint, or I'm helping them figure out how to use digital tools, I'm helping the person who's giving me so much information. And there's a lot of kind of symbiosis to have in those relationships. So I think a lot of times we have to plead and beg and boost up the profile of people we're asking to get their mentorship, to get that one-way dialogue. But I think we're more than willing, if asked, to share perspective back. And not because we want jobs or it's to take over, but it's, again, there's value to be had on both sides, and we want to learn from each other. And I think it's getting rid of the kind of intimidation and opening up the opportunity for both sides to really learn is great. And I think it's being asked. I think we have to fight so hard just to get mentors and to get into those types of relationships. And it's a little bit awkward to sometimes even get in the room, yet to give feedback is very intimidating. So I think leaders asking is a big step in the kind of right direction, because it's very hard to tell someone in a authoritative position how you think they could be doing better. And it's not meant to be in a negative way. It's a perspective, and they can also feedback and say, well, it doesn't work, and I'm not doing that because of this. And you can actually evolve that idea together.
Bobby Joe, quick thought on paying forward?
Well, I guess I would just, is this on? Can you hear me? Okay, perfect. Just to add to Rob's comment, mine are fairly similar, but I added more quick wins that I didn't say because I was 50 seconds over. I said I wrote down that give us opportunities to practice leadership skills on committees. So invite us to the table, but tell us it's okay. Because it is kind of intimidating if you have an opposite of you, as Rob said, to tell someone who's your senior leader that you don't necessarily agree.
We can still get fired.
Yeah.
Well, yeah, it's true. Sorry.
But just, I guess, maybe just starting off to say it's a safe place and teaching us, what is okay and what's not, or how, if we do have something against what you think, how to say that in a respectful manner. Might be good teachings, but just inviting us to the table. And I've seen probably the best mentorships that I've had is where we worked together on something, where you gave us a purpose, and so we learned by trying to get to that aim together, which is why I said to have joint committees. Because if you just say, well, let's just sit down and talk for 15 minutes, you might not have anything to discuss, but that will just happen organically on committees, I have found.
Thanks. Samir, comments on the concept of paying it forward. Obviously, your Oxford professor did a lot of that in mentoring you.
One of the lessons I learned, and I always tell my mentees is don't be afraid to email someone. The worst thing that can happen is they don't email you back. But I've learned, I remember, at conferences or whatever, I'd said, that guy's the expert. I'm just going to go up to them and say, hello, this is who I am. Don't be too personal space, But, there's always a balance with these things. But, you introduce yourself. Or I love it when I get emails from people saying, I'd love to just pick your brains for half an hour. And because I've had so many mentors who've always, they bought me dinner and then they said, but you know what? You buy that person dinner next. Or in the same way, I've spent this much time with you, what you need to do. And I think that's a great lesson that's been learned. And it's kind of as Leslie was saying there. The key is that we should be open, to being receptive, to individuals. But also I encourage, the leaders to do that and then ask, and because as you said, you don't want to go on the first day and say, hi, Leslie, this is actually how I want to run your hospital, right? Not the best way, right. But just, But one of the aspects I've learned in mentoring relationships is I think I could learn a lot from you. Maybe I have something I can share with you. How should we work on this together? And I think that's a great foundation to a great relationship.
So a couple more questions. Wendy, Shalom. Oh, and over here, Elise.
Yeah, Wendy Nicklin, Accreditation Canada. Thank you very much for the perspectives. And it's more of a comment, Bill, but briefly. I think we need to challenge ourselves, those who have been in leadership roles for a while, to start shifting the balance of the input and shaping the future. I really worry that one-offs, we need the critical mass of those who are coming forward to pave the future based on, I think, the perspectives that are there, so it's really relevant. And I think we need to challenge ourselves, and on boards, we need to get not one person, not two who are merging, but 3 or 4 on committees. We've really got to change the dialogue. And I think the intimidation as well would start shifting if you knew you weren't alone. That indeed, and it's respected and valued and really wanted. And I think all of us need to look at how we can situate that perspective and that contribution to really, truly be influencing the direction which many of us believe may be for the better. However, I think it would be much more rich if we really look at ourselves and how we truly value and integrate the perspectives.
If I could be permitted a comment. You're with the Young Physicians, the Federation of Medical Students, correct? One of the things that I experienced when I was CEO of the CMA was the difficulty of getting deans to give time off to undergraduate and resident trainees to attend CMA meetings. And I'd have to phone the deans and say, do you not value the future leadership of the medical profession? So I would just maybe again suggest that maybe one of the things that CEOs in this room can do is to actually value enough the contribution of emerging health leaders to let them loose for a few hours or a day once in a while. The patients are important, but so are the future leaders. So last word would go to Elise from the Patients Canada group.
So is my mic on? My name is Elise Baby. I'm with Patients Canada, and I wanted to address the issue of failure. It's my observation that the healthcare world seems to be very risk averse, And I come from the technology world, which is extremely the other way, where failure was sort of what happened on a regular basis, and you just sort of picked yourself up and said, what can we learn and move forward? It doesn't seem to be that way in the healthcare system right now. What is your experience of it, and how do you work to get to the point where the culture is supportive of failure and the learning from failure?
Rob, you want to start that off?
Give your background in technology.
Yeah, sure. I do think it's an issue, but we also have very, very high stakes. So I think there's a good reason for our aversion to failure to some extent. I think you should look at the March 4th event at, I think it's Mars downtown. It's an event all about failure in healthcare being put on by Woods College and I think HQO. Because I do think it's a cultural issue. If we can't learn from these tried and thought ideas, we're not capitalizing on the kind of richness of experience. And I think we prevent opportunities from even getting started. And I think that is in the technology world, what I see most is we shoot idea, like we kill more potentially okay ideas before they're ever even tried out or incubated anywhere before they can even let loose. So I don't even think we're very good at failing because we're so good at preventing any failure. So I think we have to be a little bit more open to working through ideas and creating cultures that will pilot and do things in small areas. I know so many initiatives that are going, cultures of healthcare units that want to try and adapt on a regular basis. I think the Center for Innovation in Complex Care at UHN is one example, and there's more kind of pockets of innovation that are trying on short cycles and trying to do 90-day pilots and see, can we make a dent in 90 days? And if not, let's learn from that failure and what can we do 90 days later. So I think it's a cultural shift that we need to work on. It's more discussing how failure is positive, and it's just the reframing of that versus hanging people out to dry where this failure is traditionally, I think, what we're very good at in healthcare, and especially with regulated professions, because we have to have a very high level of accountability. So it's just changing the dialogue.
Okay, with that, I'll invite, first off, I'd like to invite all of you to join me in thanking our guests. Thanks very much. And Frank? And now, Frank, you get to do the fun stuff again, right? Okay.
Well, one of the fun things is to thank our speakers by giving them my Valentines. So here you are.
Thank you so much.
And I want to particularly thank Bill Thal for jumping in at the last minute. And so, Bill, I have a Valentine for you.
Thanks, Frank.
Okay, so a little quick voting, and then we can eat lunch. We'll put up the questions. There's the definition of what we call the domain of disease-related programs. And we'll go then with that in mind to the first question, if we could. And the first question asks, when we're talking about clinical leadership, when we're talking about leadership in these disease-related organizations, are we talking about new leadership skills, or are we talking about the existing skills? If you think the existing skills are just fine, vote 1. If you think they're fine to some extent, vote 2. Considerable extent, 3. And if you definitely think we need new skills, vote 4. So I can see you're hungry because you started voting. Vote now, and we'll tabulate the results. Sally will tell me when we're done. We're done, and I think Therese Stuckel is in the room somewhere. She can tell you this is what's called a bimodal distribution, I think. Last question. If you can put up the last question, please. Well, we've heard a lot about new clinicians. This question asks this. To what extent do you think clinicians who are just entering practice are better prepared to engage with the goals of the healthcare system and show leadership than their predecessors? Not at all, vote 1. To some extent, vote 2. To a considerable extent, vote 3. If you think it's a whole new ballgame, vote 4. And I'm not sure what the French translation of that last one is. Maybe someone can give it while we vote. So vote on the last question. Well, that one is interesting. That is not what I had guessed when I was preparing these questions. Are we done on that one? Okay. Well, thank you very much for the voting. Thank you for your attention. We're going to break for lunch now. For those of you who had breakfast with us before the session started, lunch is in the same dining room. It's out the doors and to your right and all the way down to the end of the hall. It's a buffet lunch. It's about 12:20. Can I suggest we try to come back about 10 minutes after 1 and reconvene? Thank you very much.
I think we're free to go.
Plan of care that would assist them being more like where they needed to be in the system, as opposed to feeling like they've been moved around the system by us, that we can get to a new place. And that focus of bringing together primary care, patients, acute care, community, mental health, housing, all those systems together are key. And in fact, what the care plans are with, and again, engaging patients is one of the key parameters when people are developing health links. That it ties together the notion of the seams. I just imagine that as we do have primary care, we do have hospitals, we do have community, we do have homes. They're never all going to be one, but they can be connected, and through and sometimes you have to tighten the seam, sometimes you have to loosen it, but there's some things you've got to figure out, how do you knit them together in a way that's actually going to feel seamless for the patients. But the fact is, you're never going to take all the boxes away. So how do we bring them together and build them to make sense around the perspective of the patient of what's going to be to optimize their experience and their outcomes and reduce the cost of care, which is the essence of our AAA.
We're just about out of time. Another panel member want to respond? Yeah, Joe.
Thanks. I appreciate the question, and it's kind of interesting from my point of view, because the idea of borders is more foreign to First Nations people. Mm-hmm. We take a holistic approach in terms of life and quality of life and wellness. So it's when we work at it from our community members' side, there are no borders, mm-hmm. and those are barriers that have been set up by an external facing system that we have to deal with. But when we work with the health system, we're now introducing the wellness perspective, as I mentioned, that creates a conversation that's holistic in nature. And caregivers are already seeing, that they don't like working within those boundaries that they have. So we have a table of innovation that can help liberate some of that. And that's how we're approaching it.
So I want to thank the panel for tremendous presentations. I also, just before Frank, I'm a junkie for leadership studies and quotes. I want to leave you this quote from Mark Twain, which I think resonates with everything that's been said here. And he said, remember, never allow your formal schooling to interfere with your ongoing education. And I think often that gets in the way of conversation.
Thank you, Hugh. My pleasure to give a Valentine's gift to Hugh and to our speakers. Please join me in thanking them. We'll move to the voting. If Sally, if we could, here we go. So there are two questions to vote on. The instructions are a little unclear, so let me just quickly try to explain. The title for these voting is Pick One. And by that I mean, you'll see in question number 7, it lists some obstacles to achieving progress on issues requiring interinstitutional cooperation. Lack of appreciation of shared goals, institutional rivalry, lack of trust, lack of clear lines of authority. Pick the one you think is the strongest contributor to lack of interinstitutional cooperation. I don't know if we have that flexibility. So not getting an answer. So I guess vote on one of the four, please. And the votes are coming in. So if the distribution is equal, then that will support Samir's request. And there's a little bit of variation. Lack of appreciation of shared goals, the top one. Turning then to question number 8. Some approaches to overcoming institutional barriers historically within our system include the following: merger of institutions. I spent lots of time doing that in my career. Creation of regional health authorities, creation of disease-specific networks, joint quality improvement projects, incentive money tied to outcomes. Which of those approaches do you think has been the most successful? Pick one. I don't know. Sally says no. You can push it, but it won't respond. So pick one. And we'll wait for the votes to come in. And there we are. Number 4 is the winner, Joint Quality Improvement Projects. Thank you for this session. We'll just take a moment and I'll ask the panelists for the final panel session on leadership and policy to come up. And after just a moment, we'll begin that last panel session. Okay. Can you hear me all right? No. Can you hear me okay now? No? Can we have the mic, please? How is it? Oh, now you can hear me. Good. Well, I have the pleasure of moderating this panel on leadership in the policy domain. And in the event that we've invited our auditor to this, I promise I won't give myself a Valentine. But it's a great pleasure for me to moderate this session. Now, we have 3 speakers. Our first speaker on the program is Luc Beaulieu. Luc, I don't know how serious you were when you came up. Would you like to defer the toss to the second half?
No, because I think I'm going to take about half an hour or 40 minutes. So That's all right. I mean, because no, she's prepared. She told me, she asked me to be the first.
All right. Well, Lucas has won the toss and deferred to the second half. So, Linda, I wonder if I could call on you. The speakers' biographies are in the program. We're running a little bit behind, so in the interest of time, I won't repeat them. Let me welcome Linda Mathern from Alberta. Linda, please.
Okay. Thank you. So I presume it's just there. Okay. So I'm hoping this will go along smoothly because, like any good civil servant, I went into my slides to correct a spelling error and ended up, when I opened up the act, there was all kinds of things that I wanted to change. So hopefully this will go along smoothly. I just wanted to acknowledge some of the comments made this morning that I think fits very well into what I'd like to talk about today. So one of the comments is it's all about partnerships, it's all about collaboration. I know there's many hospital administrators here, and that's going beyond the walls and finding partnerships in other parts of the system. But it goes even further. It's into community groups. It's right down to grassroots level is what I would argue. So some of the comments made this morning, I think that weaves well into what I want to say today is the acknowledgement that the way that we approach policy development, that we approach change is piecemeal, lacks coherence, that we need collective leadership and leadership as a collective. We need a long-term agenda, and we have to give away leadership. It's all about culture change. The best, and I love this one coming from Bobby Joy. I think it's just perfect. The best mentoring for leadership is to work together on a common goal. And also connecting silos and open innovation and ecosystems are some of the things that I'm going to try and propose a little bit of a different paradigm for addressing change that we're starting to look at some levels in the organization, because we know what we're doing isn't necessarily working all that well in government. So historically, government's played the role of being the legislator, doing directional policy. We have standards, we have grants, we have plans, we have strategies. Each one of those approaches has its challenge. And really, when we look at it, I think the comment was made earlier about assets. Really, those are the assets of government when we come to the table. We tend to look at our tools as really tools that set the path. They set the migration path, say, okay, you can fly this way, but you can't go outside of these pathways. You can fly at this altitude and no higher than this, and your destination is Mexico. So we tend to use the tools that way, and it's just not working all that well for us, because to actually create change isn't about just setting the rules. So I love this quote. It's from Health Canada. It's on their website. And it really captures really where governments are being challenged right now. The policy development, while responding to ever more complex and challenging public concerns, is becoming a team sport, and government is not always the captain of the team. As a result, all levels of government will likely need to develop relationships with other actors to help achieve objectives. In light of these new arrangements, will accountabilities, risks, and rewards be informally shared on an ad hoc basis, or will they be negotiated among actors within a binding framework? Can formal networks organize and function fast enough to respond to public needs? And that's really been a challenge for government, is that need to act quickly and iteratively as policies evolve and as we see the system react. A lot of our levers are just not that flexible. So what we're doing instead, we've tried a number of different approaches. So there's, you see attempts by governments and other major stakeholders to come together as funder collaborations. So we start teaming up with other people who fund initiatives. We have small collaborations. That's very revolutionary. An example that we did is we were dealing with health workforce issues and shortages in Alberta. we had 3 ministries come together and share one pool of funds and have to do joint decision making, which was quite revolutionary for government to actually work across departments with one budget. Public-private partnerships have been very popular. I won't go into that in too much detail because most of you would be very aware of them. They've been around for a while. Multi-stakeholder initiatives where you have voluntary activities by stakeholders, so strategic partnerships. People form partnerships where they see advantage in alliance. Social sector networks, where groups connected by purposeful relationships, generally ad hoc and most often target short-term actions and information sharing. They're very powerful, but as we know, the type of change that we're talking about in Triple Aim is a cultural change, and it's a long-term agenda. So I'd like to propose, and this is something that we're just starting to look at, is something called collective impact. So collective impact comes from John Kania and Mark Kramer out of the Stanford Social Innovation Review. It's a seminal article that was written in winter 2011. And it really tries to address all the things that you've mentioned that I've highlighted at the beginning of this talk. You know, the lack of coherence, the difficulties that you have coming together, and having action over a long term. So there's 5 conditions that they talk about to achieve social change. And I just want to stop there and make a little bit of a point about the paradigm shift. Because I think for a lot of us, we've been working in a business model of leadership where you have tools like accountability mechanisms, budgets that you can incent. No, I'm okay. So you have various business tools at your disposal. I think with something like Triple Aim, and when we use the words cultural change, what we're talking about is social change. And some of those tools are different than they are under the business model. It's about, well, societal change. And I guess from a government perspective, we tend to look there because we try to look broader at the entire citizenry and some of the roles that are being played. So with this approach called collective impact, they're talking about large-scale change that comes from better cross-sector coordination rather than isolated actions of individual organizations. And that's really the crux of it. And as government, we always do grant funding. So in the flight of birds that's there, we would pick out winners and losers for grant funding and hope that somehow by funding them to go in a path that we think will be successful, we hope that it'll just catch on somehow and we'll all move together. So they share a common agenda, and that's one of the keys, that it takes time to build trust and to work through all those differences in language and to come to a common agenda. Key as well is a shared measurement system, and that actually gets to something that Leslie had just said about silos. They talk about in this model shared measurement systems being in clusters. You'll have communities where you share common measures, but then you come together in overarching. It drives toward mutually reinforcing activities, so communication becomes absolutely key, and it has to be fast, where in grant agreements we get reports every 6 months and figure out, okay, where it's heading. They talk about every week and a half, every 2 weeks, actually getting feedback on where each organization's at. And it's not feedback for government for accountability. It's feedback out to the organizations to let them know where they are in their flight path, and they see each other's results. So they actually kind of know who they're flying with and start to be able to identify opportunities. But that's with constant communication about what's happening in the flock and where the wind currents are going. To do it, it takes dedicated effort, and that's where they say these backbone support organizations are key. So there has to be a group that actually provides support to facilitate common agenda, to collect the data, disseminate, to communicate, to make sure that everybody's in the picture and understands what's going on in the big scheme. What's really wonderful about this is it doesn't dictate action, right? Your place in the flock, you can figure out how with your own assets, with your own agenda, with your own mandate, you can contribute to the larger agenda. You'll get feedback on how that's going, and you can look for your partnerships, and you can use a lot of the techniques that we've been talking about within that larger framework. So the leadership capacity, the strategic partnerships, other networks, those can all happen within, but this kind of overarches it and keeps everybody more or less flying in the same direction. And for culture change, that's really what we're talking about. That's really what we need. Yeah. Okay. So I guess the final thought is really that government's role in all this is really that government comes to the table with assets. We're not there. We don't have to come to lead. We could participate as any one of those in any one of those activities. But the assets that we come with, as the discussion carries on, it becomes obvious that we need a policy change in some area, or we need legislation in some area. And you come to the table being able to lever the whole group and contribute to the group movement. So with that, I think I'm well over. Sorry about that. Thank you.
I'll ask Shelley.
Wasn't sure if I won that coin toss or lost it or what happened. But I'm happy to go second.
Okay.
Thank you very much. Good afternoon. I've enjoyed listening to discussion and reflecting on leadership this afternoon. I particularly enjoyed Mary Jo, Samir, and Joe. And I was reminded that if you look over your shoulder and no one's following you, you're actually not leading anyone. And I think that's something we should keep in front of us. So thank you to everybody for their presentations. I'm going to make 5 points. I'm going to speak, so it's about a minute a point, about politicians, the role of civil servants, the role of stakeholders, and then 2 examples of things that I think work. On politicians, I heard this morning, I thought I heard a notion that we should be waiting for a vision of the healthcare system from a politician. And I will say, as a former Secretary of Cabinet in Ontario, we'll have a very, very long wait. I think there are a few exceptions, but few ministers I've ever met in any portfolio have experience in the portfolio they're in. So we'd be in a lot of trouble if they came into their office and within a week out they came with a vision about the system. And they actually are the people who had the courage to run, to listen to the people in their riding, put a sign up and run for election, and to represent those people. And I think we need to remember that that's actually what they're there for. Very rare is there a politician who comes in with a fix, a solution, or an idea about something as complicated as our healthcare system. There are a few, but it's an exception. And it's actually not a prerequisite for the job, just to be clear. Usually, however, they jump on the bandwagon when the public is already there. What do they want? What does a Minister of Health want from us? They want really good advice. They want to trust you. They want you to be reliable. They don't want to hear about your self-interest. So I saw a minister in Saskatchewan at one point, and she said to me, Shelley, I'm not going to go out and say you don't have to have a pap smear every year to people in public. I can't go out and say that. But if you give me evidence that says there's no point having pap smears every year, I will stand up with your report. And I was reminded that's an appropriate discussion and role. I'm going to move on to civil servants. What are their role? What is their role in this discussion? Well, they're paid to be experts on analysis, on trends, on policy. And that's what the taxpayer thinks they're there for. So these are the people who may have made their career in a specific area, who should have their ear to the ground and understand what's going on with the rest of us in this health system and around the world, frankly, is an expectation. I have a concern, and I presented at IPAC yesterday. I have a concern that we've fallen into a habit of being too passive as civil servants. I still say we, even though I'm not one anymore, in that we sit and wait until we're asked to look at something. And that isn't actually what we're supposed to be doing. We do what they ask us, and I'm worried that that's too passive. When I was a deputy at one point, was very impressed with Quebec. And Quebec, it seemed to me, in their civil service, had all kinds of papers on relevant things, all kinds of work that they did, not because the government of the day was asking them, and not in a big public way, just really smart people working on things. One that comes to mind was a high-speed rail project that they had done years ago. In comes a government, they're interested in something with Ontario to speed up trade. The Quebec civil servants pull this off the shelf, blow the dust off, update the numbers in terms of population and cost, and they're ready to go. They've been very influential. I was concerned in Ontario that what we did is we sat back and said, they haven't asked us a question. We're sitting here. We're dying to do work. Then the politicians would come and ask us, and we'd say, great, Minister, we'll be back to you in 2 years. When we've done our consultation, we've done our analysis. Very quickly, the politicians say, you people are irrelevant. They go out on the street to their very best friend who happens to know an answer. They adopt the answer. They come back and tell the civil service, here's what we're going to do because you didn't have any answers. You had your moment to give me advice. You missed it. Now, these people who are stakeholders who we know have given us the answer, just implement it. Civil services missed their opportunity to do that third-party analysis, the thing that taxpayers think we're paid for. So, stakeholders. Many of us in the room are stakeholders. My observation as a former Secretary of Cabinet is that stakeholders more often than not stood in line for money. They didn't bring great ideas, and the lineup was long, like round the block. Everybody was in line. Everybody had a story to say, if you don't fund this, people will die. And I mean, everybody said that, not just in healthcare. They said it in transportation. I could go all the way around. Said it in housing, said it in social services. So it's pretty uninspiring. It's hard to pick anybody out of that line because everybody's got the same thing. We're here, we need money. And in the case of Ontario, there wasn't any. So I often wondered, and I saw the most successful stakeholders were the ones who figured out what they wanted and figured out what the government wanted and found that sweet spot and came in and said, and I saw in some of the presentations, here's the problem you have, here's how I can solve it, and here's what I need to solve it, and made those connections. And that is how you influence good public policy, in my view. If you show up and just ask for money, I actually give you a D for advocacy and influence. That just doesn't work anymore. It did used to work, but it was decades ago at this point. So I'm going to move on to 2 examples that work. And I am now the CEO of the Canadian Partnership Against Cancer, and I think we're a very unique organization, pan-Canadian, disease-specific, so you might say pretty narrow, but 1 in 3 of you will get cancer in your life. And you will be a family member of somebody. If you escape it, you'll be a family member. So we are actually speaking to a lot of Canadians. We are 100% funded by the federal government. I think this is a plural leadership model. It takes expertise that is dispersed across this huge country and convenes brokers and networks to accelerate the work that we can do together. Is it perfect? No. Is it working? Yes. Is it getting better as we go on? Yes, it is. The first example will be the National Lung Screening trial that ended about 2 years for lung cancer based on their smoking history. We thought, how do we get ahead and anticipate the policy impact of this study coming out? Picture the study comes out, people go crazy. Why are we screening people differently than we should? What does this mean for us? So we assembled and engaged clinicians, radiologists, surgeons, population health people, patients, program leaders, and policymakers. And that group assessed the evidence in the study and the alternative responses like smoking cessation and things you could do. What's the result? The result is across Canada, experts were embedded in the system. They already were experts on lung, and they had common grounding on what they were going to say. So when the 25-year-olds who worked for the minister's offices around the country came running down the hall and said, we need a solution by noon to lung screening, there were calm voices who said, yeah, we understand. We know what was in this study. We've been meeting with experts across the country. Here's what we know about this. It avoided knee-jerk reactions. The last one I'm going to say is to do with breast screening, which came up earlier today and was out this week. And by the way, every week there's a study out on breast cancer screening. So I don't want a minister who will stand up and respond to that every week. That isn't actually the role of the minister. I don't think that's a leadership position. We want a responsible and thoughtful response to new evidence. So we connected all the people responsible for breast screening in Canada, all of them. And we made sure that they were aware in advance the study was coming, what it was going to say, and what we collectively might say. They can still say whatever they want. This is all voluntary. We don't direct what goes on here. But this is collectively what we might say. And we said we were examining the impact together of the new study. So in provinces, regarded experts are able to say that they're part of a pan-Canadian group deliberating on this very topic and on this very study. And it gives confidence. And so I would suggest to you that is influence. Thank you very much.
Est-ce que ça fonctionne? Does it work? No? Sorry about that. I've noticed that the timer is running when we're over there, so I'll speak. So I'd like to begin by saying that, no, I'm just joking, but the things that she said about Quebec is true. So thank you very much.
They're very good.
So the runner, oh my God, it's already on. If you don't mind, I will switch in French because we're in Quebec, and some of my colleagues might notice that my English, even though it's obviously my mother's language, it's okay. No, that's enough. Je vais parler en français et je vais donner un point de vue qui est lié à au moins deux caractéristiques. La première, c'est que nous sommes dans le système de santé québécois ici, et donc mon point de vue va être largement inspiré de mon expérience québécoise, même si je connais assez bien les autres systèmes en place au Canada, et je doute que nous soyons en migration vers un seul grand système de santé. Alors pour l'instant, ça reste pertinent. Et l'autre élément, c'est que j'ai une teinte forte de santé publique. Mon origine est en santé publique. J'ai géré beaucoup dans le système de santé, mais c'est surtout une perspective de santé publique qui m'anime fondamentalement. Et lorsqu'on regarde le Triple Aim, le premier, parce que je pense que c'est le premier, celui d'améliorer l'état de santé d'une population, c'est dans un courant fort, bien sûr, de santé publique. L'autre élément que je voudrais vous dire, c'est que depuis une 50aine d'années que nous avons en place au Canada à différents moments dans l'histoire, mais progressivement, assez rapidement, il y a une 50aine d'années, des systèmes de santé universels à tous les jours, sans arrêt. Depuis 50 ans, nous augmentons l'espérance de vie des Canadiens de 6 heures à tous les jours. Donc, on est parmi les plus performants au monde de ce côté. Les Français nous dépassent un plus, mais c'est 6 heures à tous les jours sans arrêt depuis 50 ans. Mais l'autre nouvelle, c'est que la contribution des systèmes de santé à cette croissance, elle est relativement faible. La majeure partie de la croissance vient de bien d'autres déterminants que le système de santé lui-même. Alors, lorsqu'on s'intéresse au Triple Aim et qu'on veut améliorer l'état de santé de population, il ne faut pas se restreindre à exploiter le levier du système de santé, mais à regarder d'autres leviers qui sont à notre disposition de manière plus souvent indirecte ou qu'on peut influencer, mais cette perspective doit être gardée à l'esprit. L'autre élément que je veux souligner, c'est ce matin, John Abbott a commencé en disant qu'en 2003-2004, depuis 2003-2004, on a investi des milliards, des centaines de milliards dans les systèmes de santé au Canada et on se retrouve avec des succès qui sont plutôt très mitigés et même douteux à certains égards. Moi, je veux vous ramener en 2004, il y a exactement 10 ans, ici au Québec, on a créé un changement majeur au niveau du système de santé. On a créé un niveau qui existait déjà, le niveau local. C'est différent du reste du Canada. On a des établissements qu'on a fusionnés ensemble. Alors, les gens tantôt répondaient à peine 1 sur 10 que c'était un levier important pour faire l'intégration et diminuer les barrières. Mais ici, on a pensé que c'était très important. On a créé des centres de santé et services sociaux sur tout le territoire. Donc, chaque population a son centre de santé et services sociaux comme institution responsable de sa santé, de ses services. Et à ce moment-là, on avait 3 objectifs. Vous allez les reconnaître. Améliorer l'état de santé de population, améliorer l'expérience de soins et faire ça de façon plus efficiente. Alors, c'était le Triple Aim. C'était il y a exactement 10 ans. On a fait ça au Québec. Est-ce qu'on a progressé positivement? Beaucoup. Au niveau de l'expérience de soins, sans doute, le continuum. On a beaucoup de choses à améliorer, nul doute là-dessus. On est loin d'être les champions sur l'accessibilité. On a gagné en efficience. On a gagné dans ces barrières-là qui sont tombées au niveau de l'intégration locale, mais on a fait très peu sur l'amélioration de la santé à partir de ces organisations-là. Et ça m'amène au point principal, le leadership pour faire ça au niveau central, au niveau du policy level, donc au niveau central, c'est quoi les conditions qui ont fait en sorte qu'on a pu ou qu'on aurait pu améliorer ça de façon plus grande, parce que c'est la question qui est demandée. Est-ce qu'on peut développer un leadership? Quelles seraient les conditions de développement d'un leadership au niveau du policy? Pas juste le politics, mais le policy. Et Jean-Louis, je ne sais pas s'il est encore dans la salle. Est-ce qu'il est là? Ah, merde, parce que je l'avais pas vu. Donc, Jean-Louis, là, il a dit des choses correctes ce matin. Mais le point, c'est que il nous parle. Jean-Louis, tu as sûrement un beigne à aller manger dehors. Mais le point, c'est que, bon, donc Jean-Louis Denis nous disait ce matin qu'il y avait différents types de leadership. Il fallait idéalement progresser vers un leadership plus collectif. Mais d'essayer d'envisager un leadership collectif au niveau central, c'est très difficile. Le contexte du niveau central, d'un niveau ministériel, et vous avez une expérience importante de ce côté-là, et vous l'avez témoigné, c'est pas facile de développer un leadership de nature collective de ce niveau-là. On est constamment en tension avec les autres niveaux, les autres organisations, d'essayer d'emmagasiner un espace collectif de leadership bien partagé, soigné, puis en même temps tout le monde chante ensemble, c'est extrêmement difficile, c'est presque dans sa nature même impossible. Une autre considération importante, c'est qu'on néglige, mais ça a été souligné tantôt, la colossale importance d'un ministre ou d'un politicien dans l'espace central. Souvent, les gens, moi, quand j'étais beaucoup plus jeune, on me disait, hein, celui qui a le pouvoir, c'est le sous-ministre ou les sous-ministres. J'ai toujours pensé ça jusqu'à temps que je m'approche beaucoup de ça. Ce n'est pas vrai. Le ministre a énormément d'influence sur le policy level et sur le leadership politique à prendre ou le leadership même dans les policies. Alors, et Madame soulignait qu'au Québec, c'est bien parce qu'on est capable de prendre des documents qu'on a, enlever la poussière dessus. On a des bibliothèques pleines de documents avec de la poussière. On a beaucoup d'espace et beaucoup de documents empoussiérés parce qu'effectivement, il y a beaucoup de production de policy, thinking, mais il y a beaucoup de décisions politiques, mais le rapprochement entre les deux et comment influencer l'autre, c'est difficile. C'est comme si on pouvait tourner la question sur quel genre de leadership on doit avoir au niveau du policy level pour influencer le politics. Parce qu'il y a une influence qui est plus que majeure, elle est dessinée dans tous nos systèmes de santé et les expériences sont révélatrices de ce côté-là. L'Alberta a pris 10 minutes et demie. Moi, il me reste encore au moins 3 minutes pour compenser. Et donc, c'est ça. Non, mais, et là, faut enlever quelques secondes de ma joke. Ceci étant dit, je veux juste vous ramener aussi sur le fait que les politiciens les policies, ceux qui travaillent sur des policies, et je fais partie de ça, là, je néglige pas qu'il y en a plusieurs autres dans l'espace au niveau central et des organismes associés. Ce sont des gens qui vont travailler beaucoup à partir de données probantes, essayer de mobiliser les gens un peu autour de ça, mais travailler dans des données probantes, travailler sur différents contextes, ça prend du temps, ça prend de l'énergie, et ils lisent beaucoup le Journal of Health Policy, le Journal of New England Journal, Journal of Epidemiology, mais le politicien, lui, il lit le Journal of Montreal, Journal of Québec, et c'est pas toujours la même perspective. Et comme Madame le soulignait, il arrive des moments où on doit saisir des opportunités. Le message le plus grand, c'est que je pense que si on veut assumer un leadership solide au niveau central, c'est qu'il faut être capable d'exploiter le concept du timing is the essence of decision. Dans un agenda politique, on ne peut pas toujours définir ce qui va arriver en avant de nous, mais on observe ce qui arrive. Et il y a des journées où, dans un contexte totalement inattendu, c'est le bon moment de sortir le document, d'enlever la poussière et de l'amener. Et d'être capable de générer ce genre d'opportunisme, ça commande un leadership qui s'exerce différemment. Autrement dit, il faut accepter les règles du jeu et accepter aussi de générer les opportunités. Donc, accepter qu'au niveau des établissements, au niveau des associations, des organisations, on puisse essayer de travailler sans doute un peu plus en sourdine ensemble pour générer des moments forts, placer un burning platform de façon plus visible pour permettre aux politiciens de s'engager dans des choses. Et on a vu beaucoup, moi j'ai une expérience qui n'est pas énorme, mais suffisante pour avoir vu de très bonnes idées de policy venir s'éteindre sur un bureau parce que le ministre va dire « Hey, c'est une bonne idée, mais il me semble qu'on a beaucoup de ce temps-là, on devrait bien. » Et c'est pour ça d'ailleurs que nos propres systèmes de santé locaux, où on pensait qu'on était pour vivre un changement radical, en changeant non seulement l'organisation, mais le repère, maintenant on doit améliorer la santé de notre population, améliorer la ligne de service, mais la santé des gens, ben ça a été là-dessus un échec. On est resté dans une dynamique très, très service et on n'a pas réussi à aligner tous les leviers du niveau politique pour permettre cela. Alors, je sais que je dois terminer rapidement, donc je fais juste vous dire que pour moi, je pense que j'ai confondu une page, mais je peux pas revenir en arrière. Ça, c'est à cause de l'Alberta, c'est sûrement eux autres ici. C'est toujours l'Alberta ici. Mais, donc, essayez de... En fait, je vais résumer ça beaucoup en vous disant que par rapport à ce que Jean-Louis disait ce matin, où il faut essayer de développer un leadership collectif, au niveau du policy, c'est presque d'essayer de développer, à partir d'un leadership collectif, développer un leadership individuel. Parce que le politicien, il fait partie d'un groupe, mais il a un agenda habituellement individuel, qui est son propre agenda de visibilité, de positionnement. Et regardez qu'est-ce qu'un politicien fait. C'est pas ce qu'il écrit, c'est pas ce qu'il pense, c'est ce qu'il dit qui compte. Et quand on est capable de lui faire dire des choses et d'engager des orientations ou des systèmes ou des changements de système, ça compte beaucoup. Alors, voilà ce que je devrais, là où je devrais arrêter parce que je vois que le time is up et là, je deviens pire que l'Alberta. Alors, merci. I'm sorry about that.
Thank you.
Vous êtes d'accord avec ça?
Merci. No comeback.
So I think Luke has a wonderful future in Newfoundland because he's got 30 minutes to work with if he moves there. Well, I have a question for the panel that I mean, we've heard some very interesting ideas in the last few minutes that I'd like to push a little bit here. Coming out of this idea of plural leadership that Jean-Louis enunciated in the morning, coming out of the comment that Leslie Thompson made about moving from the paradigm of a burning platform to a burning vision, what we've heard really from all three of you is an argument that we shouldn't look to the politician as the single charismatic leader for a variety of reasons. Shelley made a very good explanation of what motivates politicians. So that leaves us, I think, with those of us in the healthcare system responsible for bringing forward what is the important health policy concern? What are the important health policy concerns? Do you agree with that? What do you want to say about what the challenge is for those of us who are within the system to push forward policy beyond what we're doing today? Can I ask you to comment on that? Linda, you also may want to say a few words about Quebec in your answer.
I say nothing. Yeah, I think it's kind of a long-standing, and somewhere along the way we kind of lost track of this, but for people in the system, the number one relationship, and maybe I'm biased on this, is with the civil service. We're the ones that are there through changes in political regimes, if you actually belong to a province where the political regime changes. But even if it's the same political regime for 42 years, the ministers and premiers cycle, and they all come with, you know, as both Luke and Shelley were saying, they all come with different agendas. So your constant ally is the civil service. So it's really forming that relationship so they understand the issues, they understand the challenges. So as Shelley was saying, you know, working on it in the background, so when it's ready to go, you partner up and you go to the political level.
Shelley, you've answered this in your speech, but maybe you want to say a few more words. You also talked about the role of the civil service, but you challenged those of us who work in organizations to play a stronger role. Did you want to comment any more on that?
I think it's very important to have your political contacts. You should have a relationship at the political level through the minister's office and the premier's office and their staff. But don't forget the civil service. And they are in rooms that you are not in. And they can actually bring up your creative ideas. And if you've come up with something that is evidence-based in particular and well thought out, it's not just an ask for money, you want them to understand it so that they can work through the pros and cons, which they'll be asked to do. And it's better that they've heard it from you. So I say don't give up on either side of the hall and let each side of the hall do what they're supposed to do, but make sure you're touching points both sides.
Luc, you gave a balanced, but on the whole, I would say rather optimistic portrayal of the progress of healthcare in Quebec in the last 10 years. Do you think there are examples there for the other provinces?
Of course. I mean, about the healthcare system or the way we're organized or the way we work with the policy level?
Well, you talked about the reorganization and the positive effect it had.
Well, if you look at the results over the accessibility of services and level of services of everything, I think we're not the first. I mean, we've improved, but we're still, with some comparison, some place behind the group of Canada for a few things, but we're getting better. The point is that I would like to make is not directly related to that. It's mostly related to the fact that there are ways to induce our influence at the policy level of the civil servants. And I don't know if you ever observed one of your colleagues that was appointed as a deputy minister or a joint deputy minister. At first he's really willing to work, and that will last for about 20 to 24 hours, not more. And then after he's changing very fast, very quickly. Yes, it's interesting. Mm-hmm, yes. Okay. And then you see that he's stuck in the system that do not permit him to really work. I'm sorry, I'm speaking in English. Am I speaking in English?
Yes, you are. Okay. Well done.
Entonces yo voy a hablar en español. I'll switch in French for 1 minute. I'm sorry. Excusez-moi les Canadiens français là, ou les Québécois. Mais les sous-ministres et l'équipe sous-ministérielle et les membres, pas juste les sous-ministres, mais l'équipe de dirigeants ou de personnes responsables au niveau central ont leur façon de faire. Ils ont leur propre culture qui se répand très, très, très vite sur les personnes qui arrivent de ce côté-là. Et il faut pas se gêner d'utiliser les leviers qu'on a pour entrer là-dedans, puis de revenir sur leur point de départ, qu'est-ce qui les a motivés à être là, qu'est-ce qu'ils ambitionnaient, travailler avec eux, mais de ne pas leur mettre la responsabilité sur eux uniquement, mais d'essayer de travailler avec le niveau politique également. Donc, travailler avec l'espace d'équipe, de policy, sous-ministériel, etc., mais de convenir avec eux de comment on peut aller influencer le ministre ou les acteurs politiques pour qu'il y ait cette liaison pour permettre d'avancer sur un sujet, le financement, l'alignement des incitatifs, la mobilisation des médecins, etc., pour pouvoir avancer plus vite. Si on essaye juste d'un côté, habituellement, on est un peu plus perdant, je trouve. Enfin, merci.
Questions from the audience, please.
Uh-oh.
Michael.
Thank you very much, Michael Shearer, CAHSPR, Ontario. I'm going to make a hypothesis and ask you to tell me if I'm wrong or not, what we might do about it. The hypothesis is that to really get traction on transforming the health system, the plans need to be developed in an open, transparent, broadly consultative way, as well as the implementation. And my hypothesis is that civil service in Canada, fundamentally, at its core, does not work in that way. It's not open. It's not transparent. It's not broadly consultative. It works in an opaque way between government and the systems that it is trying to improve through ad hoc interactions. If that hypothesis has some truth to it, what can we do to open up this process and therefore perhaps depoliticize it?
I really think that this is not possible. It has been tried and tried and tried, and it's not possible. In the last 2 months, there was a tragedy in Quebec, and there was a policy, kind of a règlement, that was built on by the ministry, not necessarily the minister, and there was a small mistake in the wording, very small thing. And it went to the media, all the journals, newspapers, even the television were talking about that. And it was, the minister was responsible for that. He was the one responsible. He had no idea of what was going on in that small thing, but he was responsible. And they took the deputy minister or adjunct deputy minister, they put him in front of the camera, the television, and he said, "I'm really sorry about that. This is my mistake. I'm sorry." And he was sweating, "I'm sorry." And I mean, it was still seen as the problem of the other one. So they had to work very carefully, very, very carefully, and to make sure that there's always this yo-yo movement between them and the cabinet, and are we doing this thing? Yeah. So it has to be work like this. Sometimes with the permission of the minister or the leader over there, they can move on and open the discussion with the network, the partners and things like that, and people like that. But normally for a lot of very specific policy, even mostly if it's in a period of election, like we're kind of in Quebec right now, it's very delicate. So I don't think it's possible to transform that.
Samir, and I apologize, but Samir will have the last question given the time.
Okay. So Mike, I was really impressed with this panel, and Shelley, I really appreciate your comments because, I mean, the last 2 years, and my privilege of working with government, with both the political side but also the ministry, has been an incredible education. So what I've been realizing in my early career is that, first of all, as a training for medical student, that residents, etc., I received during my training was very little training on leadership in general, right? Just in terms of the clinical leadership. But then when you think about the leaders that are in this room who have to engage with government to transform agendas and move that, it's been shocking to me about how few clinical leaders and even just leaders in general, CEOs of hospitals, have really had, or any organizations, have really had training in working with government, as what you spoke. So I guess the question I have more than anything is, just understanding different aspects of leadership that one has to pertain. And we should do. I'm going to use medicine as an example in medical school. But where do you start learning political aspects? Should that be the aspect of the associations, the professional associations? Should government be offering those courses? I guess where should that be? Because I think that's helpful moving forward.
So, if I may just take a stab at that, I would say I meet people all the time who have sort of a natural born political acuity. They actually get all of that, and then there's other people who just don't seem to get it at all. If you don't get it at all, and you have the opportunity to influence either the civil service and or the political colleagues, you need some government relations help, and you need to hook up with somebody with some political acuity. So there's no shortage of people who come in and tell ministers exactly what they want to hear. But I would say to you that that's the boring part of being a minister. They really like to have people who come in and respectfully and quietly, not on the front page of the Star, lay things out in ways that aren't just in self-interest, but are system planning. And I would say to Michael's question, just sort of building on that, broad-based public consultation needs political endorsement. So if it happens to line up, then be ready to go and be ready to run it. But, very few people want to pick that on healthcare. That doesn't preclude the quieter stuff. And let me also say, for every one of you who's ever gone out and said somewhere that a deputy minister or an associate deputy minister, assistant deputy minister is against us, we're getting nowhere with them. Minister loves our idea, but she or he can't get it through the bureaucracy. I'd be a rich person. Let me just tell you, that's a very good civil servant who's actually been told not to support your idea. So understand those nuances and make sure your relationships are open on both sides of the hall.
All right, we'll move to the final voting. If I could have the last question on the screen, please. This last question was actually suggested to me by one of the panelists who shall remain anonymous. The statement, politicians should set the direction they want the healthcare system to go in and then get out of the way. To what extent do you agree or disagree with that comment? 1 to 4. Final voting, please. And the votes are in. It looks like you disagree with that. Thank you. I think this is acting like a politician. I'm going to give out the Valentines. Thank you very much. Thank you, Shel. Thank you. So I'll thank the panel again, and I'll ask Terry to come up for the final session.
Thank you, Frank. It's just going on 3 o'clock. It is my job to get you out of here by 3:30. You've been very patient all day. We started late and we're going to finish on time. But I really need your help. I need your help to engage in this last session. So the sponsors of this day wanted to walk out with something slightly short of a manifesto, which would be a set of forward-looking ideas on how we might take some of the discussion we've had today and give it expression. So, how do we build capacity and accelerate capacity, leadership capacity to meet the AAA? Luc says they've been working on it in Quebec for more than a decade. This is excellent. The rest of us haven't, and we need to kind of get with the program and move together. At the break, I was speaking to two fellows who were in the extra program, Stéphane Grou and Brigitte Brabant, about how did they find the program so far. And they said, well, it's very interesting, but it's a little bit far from where we are trying to manage the elderly, the frail elderly, and high volumes of emergency room visits in our region. So how do we build the tools? How do we kind of set out a platform of resources for training and capacity building to meet the AAA in this country? We're supposed to be incubator federalism here. We have many things that are being done in provinces that nobody else knows about. We have this absolutely spectacular program that Graham has launched. This is the most common reason people go to emergency rooms, and we do not have a standardized intervention that is uniformly being used across the country to better manage these patients with good evidence and to give them comfort and reassurance. How can this be? I think the answer is that it's a big country, and you can't take an innovation like it's a bag of chips and hand it to somebody else and presume that they're basically going to get it. We need intentional processes to generate innovations. We need innovation capacity building, and we need feet on the street and hands on the wheel that are actually working with people to spread the innovation And where is this capacity in our country? Where is it in our provinces? We have some of it. So the quality councils try to do some of this work. We have the national organizations. We have the C organizations that are there. Shelley talked very eloquently about trying to do collaborative work that bring together actors across the country. So what are your thoughts about how we do this? Whose job is this? And how do we actually mobilize some common effort in this area? Where is the resource to generate the innovations and to incubate and transfer them actively, not like handing a bag of chips to somebody? I could tell Shalom's got the answer.
I don't have the answer, but I think that's something to say. I mean, it seems to me that one of the things that's happened. One of the things that's happened is that today we've had quite a lot of description of the problems and quite a good description of some of the answers. We know and we've heard from people that we have a problem with the frail elderly in this country, that they end up coming to the emergency. Well, we understand why that is. It's because what we offer to them are hospitals and doctors and very little support in the community. We don't listen to what they say their needs are. We don't listen to what patients say their needs are. Listening to the expressed needs of patients is a really important way to start this process. And starting to listen to them and understand what those needs are helps us to understand what the next steps will be. And the project in New Brunswick and Nova Scotia of starting to deal with the feeble and the frail elderly earlier and in the community and providing them with support in the community is an obvious answer. And it's an answer that comes from all of that kind of information. So we know that we have to start that and do that. And the problems and the obstacles to that are very often obstacles that are very deep in the system. That the ear of civil servants is very often to the large players and not the small players. That the ear of government is to the people who get most of the money. And so we have problems with that. And we have to figure out how to change those things. And I believe that getting the patient voice at the table and having patients begin to speak and express their needs and make their needs clearer is a good way to start that process. And the second thing is to recognize that we can avert a huge amount of hospitalization if we provide for these needs earlier and in the community. The development of our community resources is the poorest of the countries that have been compared today. It's the poorest of the United States, Canada, and Britain. So in Britain, there is fairly good community support. In Quebec, there's better community support than there is in some parts of the rest of the country. And I think in Canada overall, it's worse than it is in the other countries. And the consequence is that we have the highest hospital costs, but we also have the biggest hospitals. So we have to think about how to change that part of the system and how we do it together. And the leadership for it started to emerge when we were listening to the younger people here, the people who were like Samir and Rob and the others who started to speak about what their role was and how they saw things. We began to see that they saw that quite true. And the question is, how do you go about helping the younger leaders lead us in the direction that we have to go?
Okay, excellent. Hugh.
Hugh McLeod. Can you hear me? Hugh McLeod, Canadian Patient Safety Institute. I heard a number of things today, and I guess I'm going to start with, first of all, a challenge. I think I said it earlier. If not us, who? And we've had far too many intellectual conversations about this very topic. A common theme throughout the day, and you can slice and dice and frame it how you will, but it's all about the patient experience. And regardless of where that patient is at on the journey, it could be in the ER, it could be the seniors, it could be in home care. And so that has to be the focal point. That's why we're in the healthcare business. But what I also heard today was pockets of excellence. Leadership at the board level, the CEO level, the frontline level, and I don't think we have figured out a vehicle to capture that excellence and use it as a knowledge transfer point to elevate the system, because there's great things happening from Victoria to Newfoundland, and we're just not capturing and using that as a learning opportunity. I also heard today of a huge gap that isn't a leadership gap. It's an information gap. How the bloody system works. And I think we just have to be honest. I had the luxury of working for Shelley for 5 years as an associate deputy minister. I wish, in all sincerity, I had made that detour earlier in my career as a leader, because I would have been a much savvier leader to understand how government works and the interface between the deputy and the minister's office and cabinet office and the premier's office. It's a very complicated system. So we're not aware of that system. Oh, by the way, they're not aware of our system, about the complexities of our system. And that to me is not leadership, that's just understanding and awareness building. We also heard over and over again the opportunity with the new, whether they be nurses, physicians, paramedical professionals, cleaners. And how do we capture them in a new conversation? And that's both curriculum design, but that's also a culture in the organization that fosters relationships and conversations. We heard that over and over again. Lastly, we can't prescribe this. We're doing too much prescription in this country to say, here's the way you must do it. It has to be built within context, just like Joe said in his environment. Our definition of leadership is different than his. The North is different than the South. BC is different than University Avenue. University Avenue is different than Winnipeg. And so context is crucial. And I think far too often we land on a network or a framework and then we try and drive it from the top down. Then we get frustrated that people don't hang their stuff on it. So, yeah, it can be a direction to move in, but it must be customized to meet the local needs and the context and readiness.
Okay. A comment back. Go ahead. Sit. I just want to make a comment on one of your observations here, which were excellent, which is what you described as a KT gap, which I would describe as the absence of being able to execute on that exact model in another place because everybody's busy. It's not that they're dumb and not listening. You actually need dedicated resources to take Graham's program and install it in Victoria or in Manitoba. You need feet on the street who are working with Graham and working with in a local context to do it. And I would like to know where those feet on the street are. This is one of our challenges. How do we actually build spread and diffusion of the many, many good things that are going on in our country, which we seem quite incapable of doing?
Oh, okay, I can go ahead. My name is Christina Miller. I'm a PhD student from Western University. And I thought this forum today was very, very interesting. And I took out two key things that kept resonating with me for most of today. And actually is both are strong influences in my own work that I'm doing. And that is really, supporting and mentoring the insiders that are doing this job on a day-to-day basis, that see the same problems over and over and over again. Instead of trying to always have outsiders come in and try to fix a problem, have it from a bottom-up or an inside-out kind of way to address some of the issues. And then the second one that I always find really interesting is that, we don't always do enough patient consultation at the beginning of the project. We run the project, we see how it works, and then we get feedback. Well, why aren't we going back and talking to these patients at the beginning, in the formulation stages, instead of at the end in evaluation phases?
Excellent observation. Maureen. Marcel, I'm going to come and ask you too in just a moment, if I may. Sorry, I missed people at the mic. Go ahead. You're here.
Actually, the Canadian Foundation for time, first of all, providing support to teams who want to make change and want to make improvements. And we've found that the most important variable in any of this happening is a leader, a CEO who actually is committed to making change happen. And so Terry has referred a couple of times to the extra program, and I know that there are participants in it here today. We took a look at the 300 or so change initiatives, implemented change initiatives from the past 10 years from teams who've gone through that program and went back and talked to them about what happened subsequently. And what we have discovered is that some, in fact, move beyond the confines of the first institution and move across the province, whether it's the use of antipsychotic drugs, which has declined through careful efforts of different assessment in personal care homes in Winnipeg, now moving out beyond a couple of care homes to the entire region, whether it's the RACE program in Vancouver that significantly reduced the time between GPs and specialists for patients with multiple chronic conditions. This is going on. But what we also realize is that often our work in healthcare improvement does not get the kind of beta testing that if you come up with a new idea in high tech, you move it out in a very considered fashion. You don't just hope it happens or that it depends on 3 people who knew the minister or the deputy and therefore it moved. So what we're beginning in March is a very considered support for spreading ideas that have proved to be useful, one of which is the significant work that has gone on at the McGill University Health Centre with engaging patients in the design of care, which has seen significant reductions in, among other things, medication errors and dramatically declining times to actually admit patients who have mental health problems. But what we're going to do is attempt to fill this spread gap. We've got to find another word for it. Spread just, I know, it's like, I think margarine every time and I hate margarine. So we've got to find another name for it. But how do we move these ideas out across the system? We're going to take a very considered approach to it and hopefully get on with it and engage with lots of you in this room in doing so.
Thank you, Marie. Please.
Bonjour, c'est Geneviève Moineau, présidente et directrice générale de l'Association des facultés de médecine du Canada. I'm sorry, I'm going to turn to English now. All of you with your earphones on. I just wanted to respond. First of all, I want to thank you for the invitation for being here. I was very inspired by what I heard today, and I come away thinking, we can actually do this because of all the smart people in the room. We can figure this out. I just wanted to respond to some comments about the medical education system and what we might be doing or not doing to support leadership. And I'd like to speak about what's happening in medical school. Many of you will know that we had support from Health Canada to develop a project called Future Medical Education Canada. And the MD project had it as one of its 10 recommendations to foster medical leadership. And it states that medical leadership is essential to both patient care and the broader health system. Faculties of medicine must foster medical leadership in faculty and students, including how to manage, navigate, and help transform medical practice and the healthcare system in collaboration with others. So that was the MD project. We then went along and did a project regarding postgraduate education. And this was done in collaboration. There was a collaborative leadership going on here with the Royal College of Physicians and Surgeons and the College of Family Physicians of Canada, as well as the Collège des Médecins du Québec. And again, independently came up with, again, a recommendation to foster leadership development. And here the recommendation is to foster the development of collaborative leadership skills in future positions so they can work effectively with other stakeholders to help shape our healthcare system to better serve society. So, these recommendations are being implemented now. It's not going to happen overnight, but I can tell you there's a tremendous movement forward in this regard. And the last thing I'll mention is that many of us, and Hugh is part of that gang, are trying to help move our CanMeds framework forward as it relates to leadership, and we're hopeful that the current manager role, which obviously is important, actually be transformed to the leader role. And we're working on it. I don't know if you saw the last version, but we might get there. So we're very excited about that, and thanks to many in this room for support.
Thank you. Lee.
Gary, I thought you asked a great question about, there's a solution out on the East Coast to a common problem, and, so why is it not happening? And I thought I'd just share a couple of things we've learned through our experience in trying to tackle some common issues in cancer. I think the first thing is that, one, we know about some gaps in measurement, all kinds of measurement that we do, and we get those gaps reinforced by the voice of patients. These things actually matter. So then how do we kind of understand those gaps together? But I think alignment is really important, and what we mean by alignment. So all of us that have worked in the health system know we've got tons of problems that we have to deal with. So how do you pick some? And how do you prioritize one over another? And respect the fact that actually that won't be the same issue everywhere. So one of the principles that we established is we need a few jurisdictions to come together and share, usually picking up that best practice that might exist on the East Coast and taking it to the jurisdictions. But not everybody has to come to the table, and not everybody has to agree that's the primary issue. And I think the second thing is, though, that for those that aren't going to actively get involved in that solution in that moment, enabling the ability to be part of the discussion as the change is happening, inevitably they'll join it. And we've seen this time again in some of the work and the major implementation work that we've done in cancer. And I just offer it up here. I think that there needs to be some mechanism to connect the solution and the gap, right? And once you've got that, then people can select what's the biggest gap that they want to work with.
So we need a solutions mart and a marketplace for innovators and solution implementers to come together.
Thank you, Jeremy.
Dr. Vial.
Jeremy Vial, hi. Just a comment and then a reminder for everybody. I think that my comment is around some of the framing that you did, Terry, around our failure around spreading strategy and execution. And it seems to me that at times one of the things that we fail at as leader is really to step up our effort to transform the system and really try to define what is the ambition for us as a nation or as a province, what it is that we want to achieve, and how do we take this ambition and turn it into very clear strategies that can really trickle down through the three levels of macro, meso, and micro systems. And at times we can be very successful, and we've seen actually exceptional leadership at the organizational level or regional level, but how do we turn that into something that's really meaningful at the system level? I think that's really one of the challenges, and I would say that we have lots of exceptional leaders in this room, and with great success comes great responsibility. And it's also all our job to try to step it up and try to build the coalitions that we need across the country to achieve some of these ambitions that we want to pursue as a nation and as a society. And obviously, it's easier said than done. We have talked a lot about some of our failures in spreading, learning from each other and spreading some of the innovations. I think that some of the national organizations, there are new benchmark networks emerging, but at the end of the day, we still have lots of micro systems, provinces, territories, federal governments that work in very similar ways. And so we do fail to learn from one another and think systematically about making change happen. So that's my comment. My very quick reminder as the president of CAHSPR is that you have actually evaluation sheets and and don't fear the Montreal weather. Actually, should be filling their evaluation sheets before. Thank you.
Thank you, Jeremy. Brian, any thoughts on this? And Marcel.
You've mentioned here the C organizations and what we can do to.
Just heard from two.
Heard from two. And there's many of them. And I think we've started to work together. I'm really glad Leslie brought up the point about silos, because there was talk about creating a super C organization, combining us all together. And I don't think that would be helpful. What we do need to do is to connect better. And we've started to do that through some collaboration with interagency group that we talked about. We definitely define leadership without borders. We're funded by governments, and in my agency's case, we get funded from the federal government and all the provinces and territories, with the exception of Quebec, who has their own agency, of course. And so I think we can help. We can assist with providing some of that information, that advice that's needed. Now, on how to mobilize what we produce, we've got a model in place where we've created liaison officers, and we've embedded those staff. They're staff of our agency, but we put them into the jurisdiction. They're in the provinces. They're in the health authorities, in the hospitals, in the ministries, bringing us information where there is gaps, where evidence might be helpful to them, and then bringing that information that we've produced and helping them implement it. Now, we've limited the number of those. We have one in each jurisdiction, and we could have 5, we could have 10. So maybe there's an opportunity for a bit of cost sharing here, or maybe the health authorities or the ministries could also look at embedding staff within some of the C organizations, or doing some sort of a cost sharing agreement for that information to help mobilize what we produce.
Thank you, Brian. Very interesting ideas. Marcel, any thoughts on this? The C organizations, pan-Canadian support, what's possible?
Yeah, let me echo some of the comments that have been made today. I really found it an interesting morning and afternoon, really thought-provoking, and I'm actually a little bit optimistic about the prospects for improving what is a great leadership capacity across the system, I think, and making it even better. And I think that the C organizations, and I won't name them, and you all know who you are, and I think I would extend that to the CIHR and the work that it's doing with SPOR and the Institute for Health Services and Policy Research, and then even some of our other non-government funded organizations like Accreditation and CHLNet and others. There is a huge resource there that is available at the national level. It is an expression of priorities, I think, at the national level, accord or no accord.
Yes.
We are moving forward with strategies around mental health, around patient safety, around e-health. So, I wouldn't bemoan that too much. That will ebb and flow. But I think that this is a really incredible platform of resources. We, at the federal level, are spending upwards of $200 to $300 million a year to support this infrastructure. And if there is truly alignment around the AAA or some variation of that, I don't think you necessarily need a minister or a politician to stand up at the federal level to say that that's the direction that we're heading towards. I think there's the leadership in the room here to define what that means, to measure it, and then to identify the resources that are available, whether it's capacity resources, the brokering of innovations from one region to another that CFHI is doing, and whether it's a sectoral thing that can be done for mental health, for cancer, for patient safety. I think all of these organizations can kind of row in the same direction, address the leadership challenge in their own way, and I think sort of build a coalition of the willing around what this national approach to leadership looks like. I'm not even sure the leadership is the right term for that. I've really been struck by the focus on patients here. Maybe we kind of need to flip that whole thing on its head. But I think there's a lot of potential there, and we can be part of it from a health kind of point of view, and we're certainly willing partners.
Thank you very much. Please, the voice of the future.
Then you might be here. No, it's Jesse Cancer with the Canadian Federation of Medical Students, and actually, I stepped up after I think it was Mark started speaking about leadership in the federal government. My comment was going to be about that, and I think of a different perspective, and the one that I was thinking of ties into Carolyn Tui's work about accidental objects, windows of opportunity, and thinking that what I imagine to be a huge opportunity for the country will be the next federal election, and I think a response from a lot of federal parties to the end of the Health Council of Canada and the Accord and the discussions around that. And I really haven't heard any talk about that today. It's maybe a bit premature to be talking about that, but I do see it as being a significant window of opportunity to engage with policymakers and say, what will be the direction in health policy, if only because health it holds so much political currency and with voters. Canadians identify with it, and I do think it plays a huge part in the direction that the country will be taking in health policy.
Very good. Thank you. Please.
Thank you. So Tom Philpott, I do most of my work, as I have for the past number of years at McGill University Health Centre, but I also do consulting work primarily in governance and leadership and such. And I know a number of the speakers from Quebec who are here today. I've known them for a number of years. And I would like to just thank them for being here. Je vous remercie et je pense que c'est la même chose pour la plupart du monde ici. C'est vraiment bienvenu. I'd like to thank the organizers for having invited them and engaged them, because this is supposed to be a Canadian initiative. And what I find all too often is Quebec is not involved in the rest of Canada. And I think we've seen today how much value there is and how many innovative and fantastic things are happening in the province.
Thank you. I couldn't agree with you more. I think, it's not a mistake that the origins of this meeting are tied to a national fellowship, one of the only national fellowships, whereas many other countries have multiple versions of this. So as a way of capacity building, it's a way of bringing together people and fellows from Quebec and the rest of Canada working with exactly the same problems, trying to tackle how to deal with problems of the frail elderly, how to deal with psychiatric patients, how to manage any number of complex health problems. Are there any other thoughts about the way forward here that anybody would like to share before we close off? Go ahead.
Terry, as you know, the document Shared Action Towards a Canadian Health Leadership Strategy Framework working paper was put out and was introduced. And I guess we would really invite comments and responses and reactions to A, the wisdom of the idea, and B, what to do to make it serve the needs of people in the room. Because this is an effort of collective action to grow the leadership capacity in the country, and we'd like to figure out how we can do that better.
Thank you very much. Any final comments or anything we haven't touched on that anybody would like to raise here today? Yes, go ahead, Bill.
Thank you, Bill Paul, CHL. Before the day closes, I just want to pick up on the second last speaker. I'd like to, I think on behalf of everybody in this room and people not in this room, thank John Abbott and the Health Council of Canada for the excellent work over the years. It has just been, I think, phenomenal last series of reports, and it's a legacy of leadership that I think all of us in this room need to carry forward. So, John, I'd like to thank you, not just for today, but for the leadership of the Health Council of Canada and on display over the last 4 years. Way to go.
Very nicely done, Bill. Let me just follow on that and first of all thank all of our very talented speakers who took the time out of their schedules to come and join us today and share their perspectives with us. Thank our sponsors, CFHI, CHLNet, and CAHSPR for putting the meeting together, and Frank Markle for being the kind of whirling dervish to help cobble together the multiple competing views into a final meeting that I think has been extremely useful in sharing a series of views on where are the issues in leadership. To Sally Clifford and face-to-face communications for being the essentially flying circus that puts together this whole show with a media team, our tremendous traducteurs who've done the translation for us, and to everybody who came today and took the time in the room, and the 100 plus people who are watching on the web, sending comments to some of us about the proceedings that are going on here today. Thank you very much. As Bill mentioned, there will be a report arising from this with some form of statement about forward-looking directions and possibilities for the future. And there's lots of room to be optimistic with the talent we've got to build on. It's just about how we exploit it together. So it remains for me to say Happy Valentine's Day and safe travels home to wherever your travels take you. Thank you so much.
Terry thought he would have the last word, but I'm going to. Terry deserves an enormous amount of credit for today. He deserves the credit for realizing that CFHI and what was initially a partnership between CAHSPR and CHLNet had something in common, and that the three organizations would all benefit from working together. So he encouraged us to bring this conference together. So I have a gift for Terry. Thank you very much, Terry, for everything.
Do we kiss? Or is that...
And if you'll just bear with me, just a few more thanks. From the three organizations, Bill Thal, Stephen Samus, who unfortunately isn't here, but Maureen, perhaps you can bring our thanks. We work together very well, and I think the strength of this conference shows what three organizations can do when they put their resources together. Jeremy Villard, who has been my president at CAHSPR, who's been a voice of great wisdom to me through this. Thank you, Jeremy. And finally, my sweetheart for the day, Sally Clelford. I'd ask Sally to come up, please. You need to come to the front, Sally. And all of the wonderful logistics. I think we've really been treated like kings and queens here in the hotel. Sally is the one who gets the thanks for that. So I have Valentine for you, Sally. Safe trip home, everybody.